Good morning. Are we going to be starting now? Sorry, I can't hear you.
ಇಲ್ಲ ಇಲ್ಲ ಕೇಳಿಸಲ್ಲ, ನಿಮ್ದು ಏನು ಕೇಳಿಸಲ್ಲ. ಕ್ಯಾಮ್ರಾ ಆಡಿಯೋ ಬರ್ತಾ ಇದೆಯಾ? ಬರ್ತಾ ಇದೆಯಾ? ಓಕೆ. ಇರೋ ಇರೋ, ನೀನು ಇಲ್ಲಲ್ಲ, ಈ ಹಾಲಲ್ಲ ಇರೋ ನಿಮಿಷ. ನೋಡಿ ಇವಾಗ ನಾನು ಕೇಳಿಸ್ತಾ ಇದ್ದೀನಾ? ಹಲೋ, ಬರ್ತಾ ಇದೆಯಾ? ಅದು ಬರ್ತಾ ಇಲ್ಲ ಬಿಡಿ, ಪರವಾಗಿಲ್ಲ. ನಮ್ದು ಬರ್ತಾ ಇದೆಯಾ ಆಡಿಯೋ? ಓಕೆ, ರೆಕಾರ್ಡಿಂಗ್ ಹಾಕಿದ್ದೀರಲ್ಲ? ರೆಕಾರ್ಡಿಂಗ್, ಥ್ಯಾಂಕ್ ಯು.
Dr. Kritika. Dr. Kritika, are you there?
Good morning, sir.
Very good morning.
Dr. Kritika here, sir.
Hi, Dr. Kritika. Shall we start the session? How many are there physically?
Physically, right now, 8, sir.
Did the Kaveri Hospital nurses join?
They have all come.
They've all come. Oh, fantastic. Okay. So, I think Dr. Suman is offline right now, right?
So Suman ma'am is also online.
Online. Okay. Good morning, Dr. Suman.
Good morning.
Good morning. Okay. Oh, that's a lovely background. Yours.
Yeah, that is my medical college, St. John's Medical College.
Oh, fantastic, fantastic. I'm sorry I was held up in the traffic. I'm going to reach there in 10 minutes.
Yeah,
But
sure.
yeah, we can actually kickstart, Dr. Suman.
Yeah.
So, yeah, over to you.
Over
Please.
to me. Okay.
Yes.
So let me see. Right. So good morning, everyone. And welcome to Namma Bengaluru for the Kangaroo Mother Care and Human Milk Banking Conference. And it's indeed a pleasure to be with you all, though it is virtual. And I hear that there are around 8 to 10 participants in person there. And we have another 10 participants online. And I think that's good enough to start off. So with the permission of the organizers, I would like to kickstart this session, and I would like to share my screen. And my topic now today is about introduction to what is kangaroo mother care, and also to talk about the components of kangaroo mother care. So, so let me start off this session. Yeah. So I'm going to share screen now. Okay. So please confirm that you can hear me loud and clear and you can see my slides well.
Yes, ma'am.
Okay. So thank you very much. And I am Dr. Suman Rao, working in St. John's Medical College Hospital, and that's the background you see behind me. And I'm also a consultant with the World Health Organization, and I have been working in this field of kangaroo mother care for the past 20 years, ever since I was doing DM in KM Hospital, Mumbai, where kangaroo mother care was my DM thesis topic. With that, I would like to talk about why we are talking about kangaroo mother care. And we need to understand that low birth weight babies constitute about 15% of all births. But you see in absolute numbers, it's quite a lot. That's 20 million babies are born low birth weight in the world every year. And the sad thing is 95% are born in low and middle income countries like ours. Though they account for only 15% of all births, they constitute 70 to 80% of all neonatal deaths. And when our goal, the whole world is looking at reducing newborn mortality, the only way we can meet the sustainable developmental goal of single-digit NMR by 2030 in India would be to focus on low birth weights and preterm babies, who constitute such a huge 70 to 80% of deaths. Many of you all who work in sort of high income settings would think that survival is not an issue in your setting. But please also remember that these low birth weight babies who do survive, and most of them do nowadays, thanks to advances in care, there is still increased risk of early growth retardation and developmental delay. And for all this, we have one answer which takes care of all the problems of low birth weight, and that's kangaroo mother care. So if you look at the problems of a low birth weight, you can actually write an entire textbook on neonatology, because whatever problems you can think of in the newborn can occur in the low birth weight. And some of the most common problems, and as nurses, what you need to really focus on, I would say, are 5 major problems. The first and foremost is hypothermia. Right from the labor room, we need to focus on preventing hypothermia in the low birth weight babies. And in fact, kangaroo mother care started as a tool to overcome the problems of less warmers and less incubators. But only then, as time, I mean, kangaroo mother care is not new. It has been there for the past 40 years. Definitely earlier than many of, you were not even born then. It started in Bogota in Colombia, in South America, with the intention of making sure that we didn't double and put 3-4 babies in one incubator. And it started as a tool to prevent hypothermia. But then we now know that the benefits of kangaroo mother care are so many. It's not just about hypothermia. In fact, in the next lecture, you will hear from Professor Asha Ben-Kappa about the benefits extending lifelong. The second most important problem you need to think of and monitor in all low birth weights is hypoglycemia. And therefore, you keep doing the heel pricks and sugar testing. And kangaroo mother care also reduces hypoglycemia to a great extent. The third issue you need to be worried about is respiratory distress and oxygenation. Again, kangaroo mother care is something that improves it. The fourth thing you need to be worried about is poor feeding. And these babies require a lot of assistance to feeding. And in fact, kangaroo mother care is one thing which, even when it's used for term babies, it is known to improve feeding and lactation in the mother. And the fifth very important one is infection. Kangaroo mother care has a special way of preventing infection, not only because the health workers are handling the baby less, because the mothers and the families are doing more, but also there are so many other ways of reducing infection. So these are the 5 major worries that you would have in a low birth weight. Of course, as the baby grows, you would have concerns of poor weight gain, prolonged NICU stay, and bonding, and all these problems can be addressed by one single tool, and that is kangaroo mother care. So now we should understand why KMC is such a total healthcare strategy. And let's understand from the basics. So I always say in nature, I mean, nature is the perfect science. And if we can do what is natural, I think we will all achieve the best. In nature, you do not have lion neonatologists, elephant neonatologists, or giraffe neonatologists. Nature takes care of all of them. And you all know that when a baby is born to any animal, it is the mother who takes care of this baby so totally. In fact, if you have, I'm sure many of you all have seen litters of puppies and kittens, at least for the first few days, you will not even know how many puppies are there, because all of them are sort of inside or under the mothers. And then you realize, oh, I thought there were 3 puppies, but there are actually 4, there are actually 5. This is all about skin to skin contact. And unfortunately, we as health personnel, in the name of medicine, have been separating these babies and mothers. And the concept is to go back to nature and realize that, why are we different? Now, in fact, if you look at the humans, what is the difference between us and animals? The first is we are 2-legged, okay, and we apparently have a larger brain. So when that happened, because our brain became bigger, the baby had to navigate through the birth canal earlier. So if you look at an animal, as soon as a baby is born, the baby starts walking, right? You don't carry around, you don't see a giraffe carrying its little one or a lion carrying its little one. Then after a few minutes or a few, maybe an hour or so, they all start walking. When do our babies walk? They walk at 1 year, maybe at around 10 months. So in fact, our babies are born much earlier than they should be, because our brains are bigger. And as we became, as the man started walking on 2 legs, the pelvis of the human species became smaller. And that is why the babies are pushed out earlier. And they are all, even the term babies are actually, you can consider them as preterm. That is why we talk about skin to skin contact immediately after birth, even for the term baby. But particularly the preterm is someone needs to be taken care of the mother for a long time. And that is what we see here. So this is where expected birth should have happened, where everybody is walking and, walking well. The children are walking well around 21 months. But this is where it happens. That is around 9 months of conception. And this in preterms, the red one, is where they are born. And here we go back to nature to understand some other animal who is born a little immature. And that's the kangaroo's baby, called as Joey. When the baby is born, it's just a few inches in size and totally hairless. And almost for 2 years, the kangaroo carries this Joey in her pouch and makes her big. And that's where the concept of kangaroo mother care has come. So when we look at kangaroo mother care, and this is what I tell most of my mothers who have a preterm baby, see, the best way for your baby to be born is, baby to be taken care of is in the womb. But now the baby is out. We can't do a reverse C-section and put the baby back. So what can we do next best? We can actually put the baby in a womb-like environment, and that is nothing but between the breasts of the mother. And this is something you have to do, not for 1 hour or 2 hours. It should be a continuous and prolonged skin-to-skin contact between the baby and the mother, between the mother's breasts. This is the first component, called as kangaroo position. The second very important one is exclusive breastfeeding. For a long time, people thought that preterm babies can't really breastfeed well. They need something else. They need formula for the baby to really do well. But now this is all proven wrong. Nothing like the preterm breast milk for the mother, for the baby. And here again, a lot of this from Professor Asha Venkappa. The last is, and this may not really hold good for the Indian setup, is early discharge and adequate follow-up. And what do we understand by that? In a lot of Western setup, they would wait till a baby reaches a particular weight, for example, around 2 kgs before they discharge. Now, with starting kangaroo mother care, the mothers became more empowered, more confident, and they would take care of the baby and the temperature would be maintained. And therefore, they started discharging earlier before the 2 kgs. Now, why did I say that this doesn't hold good in Indian setup? Because in the Indian setup, already we're discharging early. For example, in my unit, we discharge by around 1.4 kgs. And in most common setups, because we have such a huge overload of things, we do discharge when the babies are much smaller than 2 kgs. And therefore, for us, kangaroo mother care is not about early discharge. It is about a planned discharge. And more importantly, it's about adequate follow-up. So there are 3 components to kangaroo mother care. Kangaroo position, that is continuous and prolonged skin-to-skin contact. kangaroo nutrition or exclusive breastfeeding, and early discharge and adequate follow-up. So this is the kangaroo position. And you see here that the baby is between the mother's breasts. Please notice that the baby should be well supported, the bottom and the back. The head should be turned to one side. We don't want the baby onto the mother's chest, impinged on the face. Turn to one side with the head slightly extended so that the airway is open. And the legs should be well flexed at the hips. The hand should be flexed, what we call as a frog leg position. And when we do that, we want the mother to be in, this is 24 hours. So she has to walk, she has to sleep, she has to sit with the baby in kangaroo position. And here you see, but she's sitting in a reclining chair. But please remember, one position is impossible. You can't give one chair and say, whole day, mom, you sit with the baby in kangaroo position. They need to walk around, they need to sit, so they need kangaroo chairs, and they also need a bed which can have an adjustable reclining backrest. So this is important. You give around 30 to 40 degrees semi-recline, and most hospital beds are now these Fowler's beds where the backrest can be adjusted to her comfort. But don't think that these are mandatory. If you don't have that, at least give a couple of 2-3 pillows so that the mother is at an angle of around 30 degrees. So this is something you need to promote so that they can do prolonged KMC. Now the question is, who gives KMC? The word kangaroo mother care. So primarily it is the mother. But we are talking about 24 hours. I mean, it's difficult to do anything continuously for 24 hours, and the mother needs a break. And therefore, not always, but when the mother needs a break, we can have others pitch in, particularly the father. And in our Indian setup, it is usually the grandmother who pitches in and gives surrogate KMC. We have debated a lot in international conferences whether the name should still be kangaroo mother care, because we are asking others also to give kangaroo care. But we have all agreed that the mother is the most important part of this. And the word still is KMC and not KFC, like kangaroo family care or kangaroo father care, because you all know when we say KFC, you all think of other things. So the name is still kangaroo mother care. And what we need to understand that we need to give prolonged KMC. But it may be difficult to do that right from the word go, though it's not impossible. But when you put a baby in KMC, you should have at least one session of 1 hour each. It can't be shorter than that, because otherwise the stress of putting the baby and removing the baby itself is going to be too much. And you continue kangaroo mother care till the baby herself or himself decides, enough, I want to now see the world. And the baby sort of wriggles out and comes out. And this usually happens around 2.5 kg. Mind you, participants, initially when you start kangaroo mother care, some of the babies may reject it and want to come out. But this doesn't mean you stop KMC. You have to sort of convince the baby that this is the best thing for the baby and continue KMC, and baby will adjust to it. It may be just something about position or so. So we have started doing kangaroo mother care within the NICU. Initially, we started for babies who are just for an oxygen and all, but now we do even for ventilated babies. And here you see our smallest baby from St. John's, 610 gram baby, who went on to KMC in the first 3 days of life itself. And the baby is getting HFNC while in KMC. But please remember, when you want prolonged KMC, you need to have a KMC ward. And this was one thing which improved our duration of KMC from around 8 hours per day to more than 15 hours per day, having a kangaroo mother care ward. And in all government setups, it is mandatory that every NICU has an adjacent kangaroo mother care ward. And this, I would like to reiterate for even the private hospitals, even with your constraint of place and other things, it is worthwhile having a kangaroo mother care ward. And many private NICUs are now resorting to having a KMC ward. In my next talk, I will talk about the concept of mother newborn ICU. But please also remember that kangaroo mother care is not only in the hospital. We usually continue it till the baby is around 40 weeks. And so many of the babies get back into the community. And we have now data that even in the community, you can start kangaroo mother care. So how do you prepare a baby for kangaroo care? Please ensure baby wears a cap and socks and a soak-proof diaper. Wearing a jabla or an front open shirt is optional. Particularly in the very cold weather, you can consider doing it, but ensure that the chest is bare and not covered. So this is the kangaroo bag that we use, which is indigenously designed. This was designed as part of my DM thesis in KEM, and this is now used all over India. It just takes, initially it was only 20 rupees. Now with inflation, it's gone up to around 100 rupees. And this is made up of a soft flannel cloth. And what is good about this kangaroo bag, it gives the mother the confidence that the baby is safe, because the mother sort of, that there's no scope for the baby to fall down. And you can use this with any kind of Indian dress. And please keep the baby in kangaroo position as much as possible. Even routine things like feeding should be done in kangaroo position. The second component, as I said, is exclusive breastfeeding. We'll talk about it. And preterm milk is more than enough for the preterm baby, but it does need extra supplements, not in the form of milk, but in the form of minerals and vitamin supplementation is needed. And in some small babies, even fortification of feeds may be considered. How to give this express breast milk? Breastfeeding is good, but the preterm may tire out when the baby feeds directly. So all preterms and low birth weight should be offered express breast milk, which can be either, if they are very small, less than 30 weeks, they can be given by a gavage or a tube. But in older babies, more than 32 weeks, you can consider giving it by spoon as well as by palade. Palade is something that is indigenously designed, and that is good. But please ensure that the smallest baby starts sucking at the breast right from the word go. So this is what is shown, breastfeeding in KMC position. And even when tube feeding, it is good to make the baby suckle at the mother's breast, which is nothing but non-nutritive sucking. The third component is early discharge. And let me emphasize, regular follow-up. It's not only about early discharge. So there are some criteria for discharge. So as I said, weight is not a criteria, but it's important that the baby gains adequate weight, which is around 15 to 20 grams per kg per day, at least for 3 days, feeding well either directly or by palade or cup. Baby should be maintaining temperature well in kangaroo position without any assistance of the warmer. There should not be any evidence of illness, and the mother should be now well adapted to the in-hospital adaptation of KMC, should be very confident of doing kangaroo mother care, and there should be counseling and assurance of where and how to follow up. Finally, we always ask the nurse, what we have called here as a kangaroo nurse, but it's any nurse who takes care of these babies. Do you think this baby is ready for discharge? So it is finally the call of the nurse to decide whether the baby is ready for discharge or not. So once discharged, our job doesn't end. The baby has to come for frequent follow-ups. And in Colombia, where KMC got established, they call for a daily follow-up of these babies. We know in the Indian setup, a daily follow-up is so difficult. So we usually call twice a week or once a week, and what all is done during this follow-up, we ensure and look at growth, we look at breastfeeding, we make sure that the baby is well, all immunization is done, and we reinforce and talk about kangaroo mother care and care of the baby every time. If a baby is on home oxygen therapy, like you see here, we need to look at the pulse oximeter. And please remember, these are high-risk cases, so we need to look at therapy, eye examination for ROP, and other things also we need to look at. So this is a follow-up picture, maybe 20 years old from Colombia. And we also have now babies getting transported from St. John's back home. They go in KMC, and we encourage them to come back in KMC. So these are some of the things that you're going to look at on follow-up. Compliance with KMC, breastfeeding, growth, whether the baby is well, what drugs the baby is on, immunization, and the concerns. Now that we are in nuclear families, getting the baby home is good, because many times these mothers have to take on, they start off their jobs as the housewife, and they need to take care of their homes and other children. And in kangaroo care position, they can continue to do a little bit of work at home. So in conclusion, I would like to reiterate the 3 components of kangaroo mother care. The first one being kangaroo position, continuous and prolonged skin-to-skin contact. The second one being exclusive breastfeeding, and third one being early discharge and adequate follow-up. So with this, I conclude the opening session, and thank you very much for this opportunity. You're muted, can't hear you. I'm sorry, I can't hear you. You're muted.
Can you hear me, Dr. Suman?
Yes, I can hear you now. Thanks.
Thank you, Dr. Suman, for the wonderful presentation. It is really fascinating, okay, to listen to your talk. And I'm sure all the people who are present physically as well as online would really appreciate the talk. And I open for any questions before we move on to the next lecture. So any questions for Dr. Suman with regards to KMC? Please feel free.
I would really appreciate questions from the people who are there in person, because that's the only way we can interact with you.
Any questions? Yes, 1 minute.
I want to ask about guidelines in NICU. When we do KMC, how to give tube feedings to the baby during KMC?
Yeah. So thank you for asking a very relevant question to the nurses. The first thing is, before you put the baby in KMC, please ensure that your tube is well in position. And it's always good to sort of, know the marking on your NG tube where it's supposed to be at the level of the mouth. So before you give a feed, it's easier to feed a baby when the baby is on tube feeds. You just have to ensure that the mark is there in the where it's supposed to be. Aspirate to ensure that you're in the stomach. Give your feed like you would do otherwise. And the good thing here is the baby is already in upright position. So burping and all becomes very much easier after giving tube feeds in KMC position. So this is very simple. It's far more easier to do tube feeding than direct feeding in kangaroo position. Over.
Okay, next question. Yeah, you have a follow-up question.
As we know, during KMC, stomach is pressed over mother chest. So is it required post feeding? You have to keep baby 15-20 minutes as it is, and then again start KMC?
No, so KMC can be continued when the baby is getting tube feeds or feeding. And the pressure on the stomach is not really going to do any regurgitation. In fact, that helps in breathing and all. And there is no need to give some time between feeding and KMC. So KMC need not be interrupted for feeding. And after feeding, you can immediately go on to kangaroo mother care position. There is no problem. There's no worry of vomiting or aspiration.
Okay, thank you, ma'am.
Next question.
Regarding KMC for babies who are post asphyxiated, I mean, after cooling, I mean, there are children who are a little bit lethargic. So can we offer KMC to such children, and what are its benefits?
Yeah, so again, now this is a question which we do not have evidence for. Now, I offer KMC for term babies, particularly for babies whose mothers have lactation issues. Because KMC position and kangaroo care or skin-to-skin contact has been shown by benefit, shown by evidence that it improves latch score in babies and it improves the mother's lactation status. Even half an hour of KMC can improve lactation. The second time that I use KMC for term babies is when the mother we feel is at risk for postpartum depression. We use this Edinburgh postnatal depression score. And if we find that a mother is at risk for postpartum depression, which is quite common, again, evidence has shown that kangaroo mother care can reduce postpartum depression in the mothers. So these are the two evidence-based indications for KMC in term babies. What you're asking is in the field of research. Though I am not doing it, I am aware that there are studies which is looking at post-asphyxial kangaroo mother care and how it improves the neurodevelopmental outcome. The biological plausibility in this is very much there because we know kangaroo mother care improves neurodevelopment, and term babies who are at who had asphyxia are at risk of poor neurodevelopment. So it makes sense that putting in kangaroo mother care position would help the synapses and all to wire and improve neurodevelopment and make the baby more active. But this is not yet proven, but it is a very good research topic for a randomized control trial. Thank you for asking this, and maybe you could take it up as a research topic. Over.
Thank you.
One more question.
Good morning, ma'am. Ma'am, a lot of the times mothers are in the hospital for a long time and they're not able to bathe. So how they can't take a bath in the hospital a lot of the times. So is KMC okay to continue for such, because preterms are at risk of sepsis as well. So is it okay if KMC, can we do KMC still?
Yeah, so there are some prerequisites for the mother to do KMC. And one of them is her own hygiene. She should have a daily bath. Her nails should be clipped. She should wear clean clothes and then come. So I think it makes sense that if your hospital is unable to provide, every hospital where a mother is staying should have the facilities for not only a bath, but a warm bath for the mother. Please remember, they are in the postpartum period where even in our culture, we have this, it is cold and hot and such things. So making provision for a warm bath for the mother is mandatory for any NICU who takes care of babies, because it's not only about kangaroo care. Even when a mother comes in and feeds her baby, you definitely want her to have a daily bath. You want hygiene. Okay, so that I would think is a mandatory thing for any hospital to provide.
Dr. Suman, I have a question for you. It's about preterm babies. We all know that earlier you start KMC, the better it will be. However, with regards to extreme premature babies, many people have concerns about starting KMC when the baby is on CPAP or baby has umbilical lines. Then what is your advice?
Yeah. So this was, the first was, even we had these thoughts that, we are starting kangaroo mother care so late, and the smaller the babies, the later we start because they take much longer to stabilize. So in 2017, we actually did a feasibility study to see is it safe and possible to do kangaroo mother care for babies on respiratory support, like CPAP, like ventilation with lines. We did this study. The reason we did it as a study, we as doctors were convinced, but our nurses were still not, they were a little worried. So we had a protocol written, we trained them, and we did this study and showed them the data that in all 20 of them whom we did this study, all of them successfully did these kangaroo mother care sessions. Among them, we had babies on central lines, and you're very correct. Compared to CPAP, ventilation, and central lines, particularly umbilical lines, the easiest is ventilation. With an endotracheal tube, it's very easy to do, but provided you need to sort of, over the shoulder, what we do is all the tubings which are there, we fix over the shoulder of the mother so that there's no traction on the baby and the tube doesn't come out. The second one, which is a little more difficult, but doable with training, is CPAP. You again need to ensure there's no traction. And we also educate the mothers to sort of keep looking at her baby and seeing whether the procs are in place. The third, which I still find is a little bit of a barrier, and in my unit, it is only our experienced nurses who are able to do it, is to do KMC for central lines, particularly umbilical lines. So what we do is to sort of put a small gauze piece over that so that we know that it's not going to be sort of pulled. And we allow or we encourage KMC even for such babies. But it's only my senior nurses. And when I say senior, the turnover of my nurses in the unit is very high. So someone who is around 1.5 to 2 years in the unit are able to do it well. But among the three things, I find umbilical lines the most challenging, but it's still definitely possible to do it. And in my next talk, I will talk about hardcore evidence of why this immediate kangaroo care for unstable baby should be started. Over.
Thank you, Dr. Suman. And yeah, it is very important to start KMC as soon as possible. So ventilation, CPAP, and umbilical lines are not hindrance if you have proper training. And Dr. Suman, next talk, Dr. Asha is actually getting a little delayed. She is on the way. Would you mind continuing with your another session?
Okay, I can do that. Okay, so let me now share. I hope the participants, they must have been waiting eagerly for Asha madam. So, so my apologies to you that I'm going to continue, but I'm ready with it. So shall I share screen?
No, I'm sure everybody is enjoying every bit of it. Okay.
Okay, so let me just get my other presentation out.
Thank you.
My other presentation is actually an amalgam of 3 presentations. So as you see in the topic, there are 3 different aspects: counseling, monitoring, and about kangaroo mother care for the sick newborn. So I will be discussing them all in one talk, but they are going to be split. Okay, so let me start off and right. Okay, so I think you can see my screen. I'm making it into slideshow mode, and I hope you can hear me. So these are the 3 things I'm going to talk about now. I think I have around 45 minutes. How long do I have for this? Yeah, I have actually 45 minutes for this. So I would request the organizers to give me a reminder. I don't think I'm going to exceed time, but I'm breaking my talk into 3 small talks: counseling, monitoring, and kangaroo mother care for the sick newborn. You've already had a little bit of sort of an appetizer about the sick newborn, but let me start with counseling. And this is something I tell my nurses, and every time, see, kangaroo mother care and breastfeeding, both of them are behavioral interventions. You need to make people convinced that they should do it. And also remember, there is no advantage of cost or benefit to anyone. Okay, no pharma company is going to support you in breastfeeding or in kangaroo mother care. And therefore, sometimes, I mean, I must really commend Dr. Manikanti for this. You hardly find people who are advocates of this, especially maybe in the private sector. Therefore, Dr. Srinath, you are such a, I would say, special person who have been taking on this on human milk banking and breastfeeding to greater heights. So therefore, our counseling has to be extremely strong. If we need to convince a mother and her family to do kangaroo mother care, not for 1 or 2 hours, this we are talking about the whole 24 hours a day for many days together. So that is why our counseling has to be very strong. And for that, we as healthcare personnel should be first totally convinced about it. And you see here, a nurse is doing counseling, but let me come back to this picture later to just say that this probably is not the best method. This is what we usually do. We stand and we give a lot of advices to the family, but that's not counseling. So let's now look at counseling in kangaroo mother care. And anyone who can counsel well will ensure that kangaroo mother care is successful for their babies and families. So why is counseling important? Counseling would definitely, and this is all by evidence, it has shown that it increases the buy-in by the mother and family. Having said that, in all my experience, including we have done implementation of kangaroo mother care in not only hospitals, but in entire districts. We did a WHO study in Koppal district, and we worked in the hospitals, government hospitals, private sectors, community. And mind you, we never found a single family who refused kangaroo mother care. So buy-in by the family is not a problem. But the thing is to ensure that they do prolonged hours of KMC. That itself is a challenge, and therefore counseling is important for duration of KMC. Then compliance to healthcare advice. Remember, KMC is not in isolation. It's not just like surfactant, you give a drug and you forget about it. Kangaroo mother care is integrated into the care of the newborn. And compliance to all the healthcare advice is very much needed. It builds mutual trust, and it helps the family to be satisfied with the services. And even at home, when you do counseling in the hospital very well, the duration of KMC at home improves, and follow-up is also much better. Even in my own study 20 years ago, when I did a randomized control trial between KMC and no KMC, the follow-up rates of the babies who got kangaroo mother care, that KMC arm, was more than 90%. Whereas in the conventional arm, my follow-up rates was only around 75%. So the intervention of KMC itself will improve your follow-up. So counseling is vital. And who should be counseled? Please remember, counseling, it's not only after the baby is born. Very often, you are able to predict that pregnant women will have a low birth weight baby. So in such mothers, antenatal counseling should be started right from the beginning. In fact, I believe that just like BFHI, where you counsel every mother about all the importance of breastfeeding, every pregnant woman should be counseled that if your baby by some chance is preterm or low birth weight, which may be around up to 30% of the population, you please remember that you have to do something called as kangaroo mother care. And the antenatal period is the best time for counseling because they're more receptive. The mother immediately after a delivery with all her pains and aches and all is very, less likely to listen to you and things grapple and understand the issue. So antenatal counseling is the one that we need to start off with. And we have always been trying to rope in obstetricians into the counseling of kangaroo mother care. Now the question is, when should these people be counseled? Okay, so antenatally is one, and please remember, it's not only the mother. Kangaroo mother care is a family intervention. So if you have a pregnant woman coming in or a mother of a low birth weight, please call her entire family and do the counseling. Okay, don't waste your time by talking only to the mother. And please remember, her immediate family is going to be very influential on her, and they will support her if they understand the importance. And also, you need their support to do prolonged KMC. A single mother cannot do 20 hours of KMC. The surrogate has to pitch in. So all this is important. So we can have these alternate KMC providers and all. They also need to be counseled. When we talk about counseling, we should do both individual counseling, but also remember, group counseling also has its own. And especially when you have peer counseling, that, a mother who's doing KMC well talks to another mother, or a grandmother who is convinced talks to everyone and convinces. This kind of group and peer counseling really has dividends. So the counselor generally is, I would say, more often is the nurses, but and you're far better than us as counselors. Let me tell you that. Nurses are better. We are also, as doctors, we need to counsel. ASHA and health workers in the community have a big role in counseling babies, counseling families for kangaroo mother care and its continuation. And as I said, peer counseling has its own strengths. So we have to have a multi-pronged approach. Counseling for KMC is not one single person's job. All of us have to do. You can't ask, like I can't ask my nurse and say, have you finished KMC counseling? Then I won't do it. So we all have to continuously talk about it to convince the family of not only KMC, any KMC is easy, they will do it. The challenge is to do prolonged hours of KMC. And I'm sure the nurses and doctors who are sitting in the audience and listening to me will understand when I say that it's such a challenge to do any KMC of more than 10 hours. Up to 10 hours, I think we sort of manage. So counseling becomes important. And I said, there are different timing for counseling, and the messages you give is different at each stage. For example, in the antenatal counseling, you don't have to start talking about follow-up and discharge. You just have to talk about benefits, that, when should you consider starting it? How do you get ready to do counseling? That sensitization is enough. Whereas in pre-initiation counseling, it is important for them to know the exact position, what all the mother has to do to be ready to do kangaroo mother care, what are the things that she has to sort of monitor. These are the things that you have to focus on in pre-initiation counseling. Then you have maintenance counseling. So the pre-initiation counseling, if I look at what is the counseling which is going to take maximum time among all these types, I would think it's the pre-initiation counseling, because very often they may not have been exposed to an antenatal counseling. You'll have to start from scratch and say, what is KMC? What are the benefits of KMC? How do you monitor a baby? How do you get ready? So the pre-initiation counseling is one of the most important. And I'm sure that we might have time for a role play also during this time. And doing counseling is quite an art. As far as maintenance counseling, once someone is already initiated, the question is now to understand what challenges she has, what barriers she has, and to address those individual barriers and promote prolonged KMC, because that is the thing that we have to do. I think your organizers are calling me. Just give me a second. Hello. Hello. Can you hear me? I can see y'all, but it's gone off again.
Ma'am.
Yeah, that's fine.
Yes.
So just tell me where I'm not sure where y'all broke off.
The same slide, ma'am.
This slide is fine. I mean, I had actually moved on to the next slide.
Yeah, here. Time.
This
Yes.
is good. Okay. So maybe I'll just repeat what I was talking here. So sorry for the interruption. And I hope you all stretched well after your long drive to the venue. And I'm sure it's a beautiful day out there. So I was talking about when to counsel. We just finished talking about, who all the counselors. It's not a one-time counseling. All of us should speak the same language. And we did talk about that antenatal time is the best time because the mother is more receptive. And what you do at these different times of counseling is different. The messages you give is different. So whereas in antenatal, it's only about if you have a low birth weight, and we hope you don't, then there is something called as kangaroo mother care, and you should just be aware of it. Okay. These are all the benefits of it. That's the message. That's the only message you need to give. The next one is on pre-initiation counseling. And as I was talking, I don't know whether you all heard me, that this is the most important counseling. Because very often when we have mothers who have low birth weight, they have not had any counseling of KMC. They have no clue of KMC. So we need to start from scratch that this is kangaroo mother care. What does it mean? What is KMC position? What do you need to do to ensure that you give good KMC? Actually do it on her and continue the counseling. So this is the one which is going to take the longest time and bring in the family and everyone into it. The maintenance counseling is mainly focused on improving the duration and individualize the intervention. That is, what are your problems? I see that you have done only around 6 hours of KMC. What are the things which is making you not give KMC for the rest of the 18 hours? So try to find out her individual problems and address that during this maintenance counseling. And then we have the very important pre-discharge counseling, where KMC is only one aspect. You have to talk about a lot of other things in discharge counseling, including danger signs, where to come, what to do, what sort of early intervention you need to give at home. All these things have to be discussed. And also the very important message on KMC is how to continue KMC. In fact, you can sort of understand her day in her house, how it's going to be, and see how KMC can be well fit into her day at home. And then it is important that someone visits home. And this is where the government ASHA health workers come in. Unfortunately, in the private sector, we don't have any such thing. But maybe at some point, we will reach that stage like in the UK, where you have nurses going home for even normal deliveries and making sure that the babies and the mothers are doing well. So this kind of counseling will have to be done to continue kangaroo mother care at home, again, understanding individual barriers. Now, when we come to counseling, and if you can take this one single message from my presentation, it is enough. Please think of the word gal pack. And remember, counseling is not only about kangaroo mother care. We do this all the time when we talk with our patients and families. Just remember the word gal pack. And when you talk to them, think of, am I doing gal pack or not? So what is gal pack? First is greet. Just namaste, how are you? You know, that kind. Then always ask, what do they know? And remember in a counseling, and I often do it when my residents are doing counseling in the counseling room in St. John's, I just sort of stand out and see. And my only thing I'm trying to hear is, who is talking more? Is it my doctor who is talking more? Or is it my patient who is talking more? And in a good counseling, there should be at least equal discussion. If not, that the patients, poses a question and then you answer it. So always ask them to know what they understand, what they are doing. And remember, counseling is not quick. It takes time. Then when they are saying, you patiently listen. They would have told you stories and you have to pick out only what you need. But at the same time, you have to pay attention, because you can't go back and say, they would have said, I have a child at home. Then after some time, you can't ask them, how many children do you have? So those are things that we should avoid in good counseling. We should listen attentively and remember and find a reason to praise them. Don't praise unnecessarily. Okay. For example, if a mother has not come for 5 days, and then only on 5th day she comes. One of the tendencies is, why didn't you come all these days? Your baby has been waiting for you. You're not giving milk. All of us have this thing to say these things. But find a good reason. Find out what happened. What happened to you 5 days? You had pain. What are the issues? And then, oh, good, you're at least come now. Your baby has been waiting for you. We are so glad you have come now. Despite all your pains, you have managed to come. Find something positive to praise the mother. And then limit your advice to only what is relevant at that time. When I'm doing pre-initiation counseling, I don't have to talk about danger signs that she has to find out from home. So do we again have a break? I can see the colorful signal out there. Am I audible and are you seeing my slides? Organizers, please let me know. Please let me know if I should continue or stop. Shall I continue, please? Organizers, may I know if I can continue? Is there an issue out there in the venue?
Ma'am, you can continue, ma'am. We can hear you.
Thank you, because I thought there was a power failure again.
No, ma'am. Sorry.
Okay, so just advise and then check what they understood. You may have said very important things, but they may not have grasped it. Remember, they have their own issues to deal with. They may be sort of reeling under the realization that they have landed up with a 1 kg baby. It means so much of cost, so much of hospital stay, and all the worries of how this baby is going to grow up. So please remember GalPack, and always when you talk to families, use these principles. And remember, counseling is not about how you just talk. In fact, communication is only 20% words. The rest is all non-verbal. So you have to give an importance thing to how you sit. Remember to remove your barriers. I have a large book, I have my stethoscope, all keep it at the side. Show that you're interested in. Maintain eye contact. Maintain eye contact. And don't fidget with things. Look around, show that you have other things on your mind. Don't give them negative clues. So this non-verbal communication is something that we need to build up. And these counseling skills are not only for kangaroo mother care. This is absolutely essential for us in anything that we deal with regarding our patients. So the key messages I would like to give, and this is the end of my first session on counseling. Counseling is vital to success. First and foremost, we as health personnel should be totally convinced that there is nothing better than kangaroo mother care for the low birth weight baby. And counseling should start in the pregnancy itself, and tune your counseling to decide whether am I doing pre-initiation counseling, maintenance counseling, pre-discharge, or even home counseling, and ensure that your counseling is tuned to that, and check on the mothers what they have understood. And as I said, from this counseling session, you should take back one word, GalPack. I'll be happy with the session. So what I'll do is move straight away. And I think if you all have any questions, we could take that all together at the end through my 3 sessions. And the second session is also a very short one on monitoring during kangaroo mother care. And I think as nurses and doctors, the biggest challenge we face when we are dealing with, say, an 800, 700 grammer is giving the responsibility of this very vulnerable baby to the mother. We are scared. How will the mother see this? Will she able to know when there's an apnea? What if the baby becomes apneic and something happens on the mother's chest itself? These are our valid concerns. So we need to.
Dr. Suman, sorry to interrupt you. I think there's a power failure here. Just for last 1 minute, we could not hear you.
Okay. So do I continue? Do I?
No, if you just pause for 1 minute.
Yeah, I'll do that. Please let me know when to restart.
Yeah.
Yeah, no problem. Yeah, okay, fine. Asha ma'am is on the way.
On the way? Online is working.
Yes,
Only
sir.
offline is not. Oh, this is you, right?
It's on.
Why it's not connecting?
I think the LAN network is not good.
Recording in progress.
Oh, yeah, Dr. Simon, you can continue.
Okay. So I hope you have listened to the key messages on counseling. Do I have to repeat this?
Only the key messages, ma'am.
Okay, so I'll just repeat the key messages. So as I said, counseling is vital to the success of kangaroo mother care. And we as healthcare personnel should be totally convinced about it. Start right in pregnancy and make sure you tune your messages to depending when you're doing the counseling. And each phase has a specific message. And I said that if from today's lecture on counseling, you take back and remember only one word, GALPAC, that is this enough to make this lecture a success. So please remember GALPAC. And I requested you all to sort of note down your questions if you have any, so that I can take it all up after my 3 small talks are over. And I'm now jumping into monitoring during KMC straight away. And we know that when we start KMC, nurses and doctors are worried that will the mother be able to, take care of the baby. So please remember, yes, mothers are doing kangaroo mother care, but it's still our responsibility to ensure everything moves well. So we have to continue to do this monitoring. And at the same time, we have to empower and teach the mother to do the monitoring herself. So in many places I've seen, particularly in Africa, I have seen mothers themselves taking the temperature of the baby. They keep even in KMC position, they measure the temperature. We have been used to telling them to do the temperature by the touch technique, but even 4th hourly, we can still continue to monitor the temperature of the baby. So teach the mother how to take temperature with the digital thermometer. If that is a problem, at least by touch technique, that the baby's tummy and the hands, because the hands are easily away, outside here, the mother should feel the hands and ensure that they are nice and warm. The next important thing is the airway. Ensure, ask the mother to close her eyes and feel if the baby is moving, whether the baby is breathing. So most mothers are able to feel that, and that will show that the baby is not having apnea. The smallest of the small babies, when we start KMC, even before they're unstable, we ensure that they're always connected to a pulse ox, and we teach the mother that please let us know if the saturation goes below 90. So we have to tell them which is the heart rate, which is the saturation, and most of them are able to alert us. And the head of the baby should be turned to one side so that the airway is open in a slightly sniffing position. So mother is able to identify the breathing, and it's a good thing to connect the pulse ox all the time when a baby is in KMC, if the baby is still small and unstable. Mother can look at color, but color, remember, it is a little difficult for them to appreciate cyanosis, but yes, you can also teach them that. The other thing to focus on and monitor is feeding. These babies are small and many of them still need 2-hourly feeding. And whether, one of the questions which was so nicely raised, we have to teach the mother to give feeding, as part of family participatory care. Mothers can give tube feeding, mothers can give pala-day feeding, and we need to encourage the mothers to, sort of just loosen the bag and give pala-day feeding, keeping the baby in KMC position. One of the challenges they face is to express milk with the baby in KMC position, but especially if they can have these new garments which allow expression of milk with the baby in KMC position. And even if these new garments are not available, just wearing a shirt which is fully open is enough for just opening it out and expressing milk as the baby is in KMC, and even feeding the baby in KMC position. And they have to ensure that they are very clear on how much milk to give. Did the baby take it? Was there any wastage? Because growth is important. That's the other thing we as doctors and nurses should monitor. And we use something like this. We call this the KMC compliance sheet or the KMC chart. And we ask the mother to sort of tick. These are all hours, 24 hours in a day. And we have, even for illiterate mothers, we have, showing that this is morning, this is, noon and night. And they have to sort of tick in that how long they did KMC. And we use this compliance sheet all the time to show that, see, you did yesterday 10 hours of KMC and your baby has put on 20 grams of weight today. So we use this effectively. Of course, we don't show them if they have done good hours of KMC. And for some reason, the baby, may have had a big stool and may have not gained weight. So we use this tool appropriately, even as a tool to motivate mothers to do kangaroo mother care. So it is important that we continue to monitor the baby until the mother is confident, and the mother should continue to monitor the baby even at home. And these daily monitoring charts should be brought for follow-up. And of course, if the baby is small and sick and we are doing KMC for an unstable baby, continuous monitoring of this baby by a pulse ox is mandatory. So the key message is, putting a baby in KMC doesn't mean that monitoring is not there. In fact, I would now say it is double monitoring, because you have your doctors and nurses and pulse oximeters monitoring. And at the same time, the mother is also educated to recognize the danger signs and respond immediately. So monitoring is vital, and they need to continue to monitor the same as if the baby was, even if the baby was not in kangaroo mother care. Now, the question is when to start KMC. KMC should be started. Nowadays, we started, I'm going now to the third part of my talk about KMC for the sick baby. 20 years ago, we started kangaroo mother care only once the baby became stable, because then the kangaroo mother care guidelines by WHO, which is changing only now this year, it said that you start kangaroo mother care once the baby is stable. And this would usually take around 3 to 4 days or 5 days. The smaller babies would take much longer to do kangaroo mother care. But immediately, I think within a matter of 2-3 years, when we started KMC, we got confident of doing kangaroo mother care for babies on IV fluids and oxygen. And that's what you see here. But now the whole concept is about immediate kangaroo mother care, even irrespective of whether a baby is stable or not. And I'll talk about this fascinating study, which I had the privilege of being part of. And in St. John's, as I said, we just discussed this for a very nice question from Dr. Srinath. And we discussed that we did a feasibility study of babies on CPAP and babies on ventilation, 20 babies whom we were able to successfully give kangaroo mother care on respiratory support and even lines. And if you're interested, this paper is available on PubMed and you can read it, how we did a feasibility study just to ensure and get a buy-in from all the nurses that KMC for the sick neonate is possible. It was at the same time when I was already convinced that KMC for the stable baby is possible, was a large study conducted by the World Health Organization. And why did they do this immediate kangaroo mother care study? Because they realized that, or if you look at, and in here, I do think that even for nurses, it is always good to know about evidence. And you all may be aware that the Cochrane meta-analysis is the highest body of evidence that we have. And it showed that the duration, the benefits of KMC are immense. And you'll hear more about it later by Madam. But it showed that the mean duration at which KMC was started was around 3 days. And the range was from 10 hours to even 25 days. And we know that newborn mortality, the maximum mortality is in the first 24 hours. And among them, the first 3 days is very, very important. So when we say that KMC reduces mortality by 40%, half of them are not even eligible for KMC because they're unstable. And majority would have died. Therefore, WHO or World Health Organization came up with this question that if we start continuous KMC immediately after birth, compared to after they are stable, will it make a big difference to newborn survival? And here we are talking about large, important outcomes like survival. And this was a huge study. It was a multi-country study done in 4 African countries and 1 country that is in India, in Asia. It was done in Safdarjung Hospital. All babies between 1 to 1.58 kgs, irrespective of whether they were stable, how sick they were, got randomized into either kangaroo mother care or they got randomized to control group. And please note here, The control group is not no KMC. Control group also got kangaroo mother care, but they got it once they were becoming stable after the first 24 hours. And then even in the control group, they all went back to the same KMC ward, both intervention group and control group. And this was a large study, as you see here, with more than 3,000 babies across India and in Africa. There were 3 components to this study. And the first component was continuous skin-to-skin contact, starting with the mother. And sometimes the mother was not there because we are talking about starting KMC within the first 2 hours of birth. So we used a surrogate. And irrespective of the mode of delivery, many mothers, you know, the small and sick babies are usually born to mothers with problems on C-section is much more common. So even there were mothers, many of the mothers, I would say 75% had a C-section. So therefore, we needed surrogates till the mother sort of stabilized. But kangaroo mother care was started within the first 2 hours of birth. And in them, we aimed at doing more than 20 hours per day, even in the first 3 days. And continuous KMC was continued in the KMC ward, and in the intervention group, they started it after they became stable. The second component was even in the small babies, there was support for breastfeeding more. They were put, even if they were on CPAP, they were made to suckle on the breast, and all medical care. Like, for example, if you needed to do any samples, you needed to provide CPAP, all of that was continued in the KMC position. This is a picture from Ghana, where you see this mother giving a KMC to a baby who is on CPAP here. This is the picture from Safdarjung Hospital. So I said there were 5 sites. In 2 of these sites, one in Tanzania and one in Safdarjung Hospital, India, they actually created a new ward called as Mother Newborn ICU. If we are asking the mother to do kangaroo mother care for more than 20 hours per day sitting in the NICU, and remember, these are postpartum mothers. It is not right of us to expect a person, that to a postpartum mother, to just sit with kangaroo mother care. You have to make it comfortable. Like one of the questions we said that you have to make sure that there is warm water available for a mother to have bath when she's in the hospital. Similarly, if you want immediate kangaroo mother care for prolonged duration, we need an adult bed in the NICU. And this is what was created, a separate NICU called the Mother Newborn ICU. It was just like any other NICU with a warmer, with all your monitors, with CPAP machines, but also there was an adult bed where a mother could stay with the baby in kangaroo position. And this was done in both India and Tanzania. Whereas in the other 3 sites, in their original NICU, one area was created where adult beds were put. So having adult beds in the ICU is mandatory for us to do immediate kangaroo mother care. And even to my surprise, because I have been struggling with duration of KMC in my own unit, I sort of rejoice and say, oh, 10 hours of KMC. But what we saw in the study was really surprising. Even in the first 3 days when the baby was sick, we managed to provide kangaroo mother care for more than 17 hours per day. And this was the average across all the 5 sites. And that was really rewarding to know that sick babies can be managed for as long as 17 to 20 hours in kangaroo mother care, even in the first 3 days, even when they are getting respiratory support and others. So this is a picture of how the control group, the other areas where mothers were allowed to come in, but they were like visitors and they hardly did any kangaroo mother care. And this is this study got published in NEJM. And NEJM, as you all know, is the one with the highest impact factor as far as medical research is concerned. And this study had showed that if you see here, this is in comparison of immediate KMC with conventional KMC. And here the conventional or the control group also got very good kangaroo mother care. The average duration of kangaroo mother care before they went back home was 20 hours per day, even in the control group. So this, we are only talking about an additional KMC in the first few days of life. And that itself brought out a reduction in mortality by a whopping 25%. And in fact, this reduction in mortality is so huge that the Data Safety Monitoring Board said that no more study. We have enough evidence now. Our sample size was actually 4,500. We were planning to enroll 4,500. But the DSMB said that this is one trial which even before you have finished the sample size has shown benefit. And let us now stop the study and make it practice. And not only about mortality, as suspected, hypothermia was reduced by 35%. Infection, this was something that was fascinating, because when we started immediate KMC, nurses and doctors were worried that if I allow the mothers to come in, not only the mothers, the surrogates, the grandmother, and be there in the NICU 24 hours a day, will they not bring in infection? Will my infection rates not rise? And for us, the delight was to see that there was not only no increase, but there was a significant reduction in infections. And just this is a point to note, that even when there is, the family is participating more in NICU care, infection rates do not increase, because the bugs that they have are all commensals. The bugs that we have are nosocomial, and they are the ones who are going to cause infection. So this particular study has a huge implication for policy change. Now, this is going to be the new way an NICU is going to be designed. And this is for all our neonatology friends who are planning to start new NICUs and scale new heights. When you plan to, you design an NICU, please design an MNICU, where the mother and the newborn can be together with zero separation. And this also showed that even though we say the mother is there, you still have to provide all the care of an intensive care. You need warmers, you need ventilators, you need CPAP Hello? Can you hear me?
Ma'am, we can hear you. Can you hear me, ma'am?
Yeah, I can hear you. Can you see my screen?
Yes, ma'am.
Okay. I'm sorry. I think, I lost my Zoom connection when the power went off, I think, and I had to log in again. So was all this covered?
Yes, ma'am.
Okay. So I think I was here. So a lot of interruptions, but that is how it is. And we don't want many interruptions to kangaroo mother care. And we see here in this study that they managed to get even 20 hours of kangaroo mother care. And even when we start an MNICU, all the facilities of an ICU should still be there. But the only difference is the mother's adult bed should be there. Please also remember her comfort is important. So we need things like a pantry, washing area, an area for her to have a bath. And there should be training modules to ensure that the mother and the surrogates and all her family members who come in are all well tuned with the infection control protocols. This one study, it had other benefits. It showed that finally, it is the obstetricians and the neonatologists who need to come together for the benefit of the baby. So in this MNICU, like us neonatologists who do rounds in the ICU, the obstetricians also came to see. Please remember the babies who are small, their mothers are often sick. So the obstetricians would do twice a day rounds to ensure that the mothers were well. And the other important thing is conviction of the health workers. Now, once you do this kind of immediate KMC, you will know what a great benefit there is in zero separation. Lastly, I just want to say that the COVID-19 pandemic should not be a barrier for kangaroo mother care. We have published studies which show that the benefit of doing kangaroo mother care and the lives saved by doing kangaroo mother care is far more than the lives which will be lost, even if the mother has COVID and even if the baby gets COVID, because COVID in the newborn is not very dangerous. By denying kangaroo mother care, the danger to the baby is much more. And this sensitivity analysis, we showed that the risk of not doing kangaroo mother care and dying from that compared to dying from COVID was the difference was more than 600-fold. So this is enough to tell us that kangaroo mother care should be done for all low birth weight babies right from birth. Continue it during the facilities. Make sure it is done well, you counsel well, you monitor well, and continue it at home. Thank you very much for your patient listening and being patient with all the technical glitches that, power and these things we are having. I hope you have a fantastic workshop and even better conference. Thank you and bye. I'm not able to hear Dr. Srinath because I think the audio is muted on the Zoom. Yeah. Now.
Can you hear me now?
Yes.
Thank you, Dr. Suman, for the last couple of hours of intensive advocacy on KMC. Now, I'm sure all the participants would have realized what is how important the KMC is. And these are the people who are participating. They are the people who actually can help these mothers to spend as much time as possible, okay, to do the KMC. And thank you very much. It was really fascinating listening to you. Okay, so for a change of topic, so we're going to human milk banking now. And then after that, Asha madam will continue on the breastfeeding and KMC. Okay, so soon after this talk. Thank you so much.
Hi, Anjali. You'll have done your rounds. Are you in your conference or something?
Yes, ma'am. I'm with Mini, ma'am. Yes.
No, no. Are you okay? You're doing rounds with Mini.
Yeah, yes.
Okay. Once you finish that, will you come to the office?
Yeah, I'll come.
Okay. How long it will take?
I think another 10 minutes.
Okay, fine. And you
Yeah,
call
fine.
Sunita or Shilpa also. We'll have coffee and then we'll start
I'll tell
rounds.
her.
Thanks.
I'll tell her.
Yeah.
Yes.
I'll start. Kaveri Hospital, Bangalore. Areas of interest: neonatology, neonatal cardiology, perinatology, and donor human milk banking. Achievements: instrumental in setting up first public human milk bank, Amara, in Karnataka in 2017. Recipient of first edition of Times Healthcare Achievement Award in Neonatology in 2018. Given oral presentation on human milk banking at World Pediatric Congress, Berlin. Featured in Medgate, top pediatricians in India, Coffee Table Book 2020. Received Presidential Award from
Sorry, I have to focus here, is it? Huh? I'll say next slide. You can just move. I'm sorry for the technical glitch. So in the next half an hour, so we'll talk about how to set up a human milk bank. So human milk banking is not new. Okay, so it was new a few years ago. For example, when we started the first human milk bank in 2017 in Karnataka, there was no milk bank until then. There were a few milk banks in around the country in different metropolis, but not in Karnataka. So now human milk banking revolution has started. So currently Karnataka has 3 working human milk banks, and few are in the pipeline in the very next few weeks and months. And in another 1 year, we'll have more than 10 human milk banks in Karnataka. And we can be one of the states where they can actually look up to. So warm welcome, and for any people who are joined online. So greetings from Garden City, Bangalore. And definitely, if you're not visited Bangalore, you missed out on this beautiful weather and beautiful Garden City. Next time you get an opportunity, please do visit us. So I'm not going to talk about the importance of the human milk bank, because that talk will be covered by Dr. Manoj, who is on his way. So we all know how important human milk is, and breast milk is very important for all the babies, and it is advisable to exclusive breastfeed all the babies for 6 months and continue to breastfeed until 2 years and beyond, with starting complementary feeds at 6 months of age. And it is 10 times more important to preterm and low birth weight babies than even the term babies. Why it is so? Because breastfeeding has found to be protective for these preterm babies who are vulnerable at risk of severe complications like necrotizing enterocolitis, which can happen when these vulnerable babies get exposed to formula. And preterm and IUGR, the breastfed babies have better survival and decreased rates of infection. Okay, and these babies reach full feed so faster. These babies have less infections, both early onset as well as late onset sepsis, and these babies get discharged early from NICU. All this will be covered by Dr. Manoj in the next talk. Okay, so unfortunately, these are the most vulnerable babies. In the initial phases, their mothers are unable to lactate enough to meet the needs of these babies, and human milk banks actually fill the void. very challenging. Healthcare has adopted. So online consultation started, right? So now almost I do 30% of my consultations online. And I get consultations from different parts of India, sometimes even from abroad, from Europe, America, like that. And connectivity has gone huge. So every adversity brings it equal better benefit. So we need to be adaptive. Anyway, we'll be patient. We'll just, are we online? Okay. Hope you're all vaccinated. 2 doses or 3 doses? Officially, yes. Yes. So how many of you have heard about Human Milk Bank before? You have heard about Human Milk Bank. You have heard about. You heard about Human Milk Banks. Yes, that's good. Okay. So when we actually started Human Milk Bank in 2017, so many people, when we actually approached them that we are going to start a Human Milk Bank, they were asking, what is this? We heard about blood banks. We know about semen banks and ovum banks, but not the Human Milk Bank. Human Milk Banks are supposed to be there for, it came. They can hear now? Okay. I'm really sorry for the technical glitches. Anyway, it won't hamper our spirits. Let us continue. So this is one of the only public human milk bank which caters to vulnerable preterm babies across all hospitals wherever they are born. And first human milk bank in India with collection and delivery system. In fact, we started this before even Swiggy and Zomato got famous. Maybe they have taken idea from us and then probably become famous after that. So the idea was that, and it is one of the first milk banks with breast milk analyzer, where label nutritional value of the milk is printed on each bottle. And this is the inauguration of the milk bank in 2017 by a vice president of European Union at the time. So what are the equipments we need to set up a human milk bank? So we need a pasteurizer. Okay. Why do we need a pasteurizer? Because we pull the milk from different mothers, and it is important that we pasteurize the milk to make sure that the milk that are giving to these vulnerable preterm babies is safe for consumption, right? During the pasteurization, so most of the the pathogens get killed. And we need at least one pasteurizer. And you can see, there are different sizes of pasteurizers. So this is T13 and T30 and then T90. T90 does about 50 bottles. To collect the milk from the mother and before pasteurization. And another one is after pasteurization, we store that milk separately in a different deep freezer. And in the deep freezer, it is advisable to have a good deep freezer with a display of the temperature. We need to maintain the temperature below -20. And at least one refrigerator. Why do we need a refrigerator? Because these frozen milk, which is coming from the mother, when it is stored in the deep freezer, and before we do the pasteurization, we need to thaw it. We need to make it liquid. I'm sorry about. So many technical glitches are happening. Back. These are true adversity. Okay, this really tests our spirit. ಯಾರು ಬಂದ್ರು ಮೇಡಮ್? Oh, is it? Maybe accidentally got disconnected. Huh? Projector also stopped. ಏನಾಯ್ತಪ್ಪ ಪ್ರೊಜೆಕ್ಟರ್? ಫಿಕ್ಸ್ ಇದೆಯಾ? Until it comes back, and we have a quick round of introductions. Okay, at least people know who we are. Okay, so start from here. That's a good idea. Yes, yes, yes. Okay, and you electronics. Yeah, I'm also working in curate. Dr. Dinakar is also working. And where do you work? You say, which area you are working? Yeah, that's important. Yes. Oh, it came. Okay, fine. Online, are the people able to see? Is it logged in? Are they able to log in? No. They're able to see. Okay, fine. So we're talking about a refrigerator. Refrigerator is used to thaw the milk overnight so that the frozen milk is kept in the fridge overnight, and by the morning it is thawed into liquid form, and that milk we will actually pull it under the laminar flow, and then we'll do the pasteurization. And we need a one laminar flow where we can actually pool these milk, and then under the aseptic precautions to avoid any infections. And we need a human milk analyzer, and ultrasonic processor is an optional. If you have enough funds, then you can actually go for human milk analyzer, especially in the teaching institutes where they want to do research about the components of the milk and what is the composition of a preterm milk, term milk. Okay, so if they want to do some research or individual fortification, then they can go for the human milk analyzer, but that is not mandatory. Okay, it's an optional. It is like having a meningococcal. It is like a rain interrupted cricket match. So what is the cost of the equipment? I'm just putting what exactly cost us actually setting up Amara. So basically, if you go for the T30 pasteurizer, it costs about 12 to 13 lakhs. If you go for bigger S90, that 30 to 31 lakhs. And they're all automated. And the brush pumps manual costs about 2,500 to 5,000, and automatic costs more, actually about 1 to 1.85 lakhs. And deep freezers, if you go for thermoscientific deep freezers, roughly around 1 lakh. And horizontal, you can probably get it by 50, 60,000. And refrigerator and human milk analyzer. Look at the human milk analyzer cost. So 30, 31. So that's why I said it is like Manectra injection, where it's the most expensive vaccine, but it's an optional vaccine. Okay. Here it is optional. If you have enough funds, yeah, you can go for analyzer. And laminar flow is not that expensive, and BFA containers are must, and they're not expensive either. So what is the screening process? Potential donors, we take a consent. First, we'll ask the questions, are you healthy? Are you on any long-term medications? Okay. So any short-term medications like paracetamol for fever or antibiotics, or even insulin or thyroxine is okay. Apart from that, any other long-term medications, we do not advise the mother to give this thing. And also, the first question we ask, are you breastfeeding your own baby? If she's not breastfeeding her own baby, we would really straightforwardly reject a donation. Okay. And we do the history and physical examination. After that, we do screening for these diseases, HIV, hepatitis B, hepatitis C, and VDR. Okay. You may ask, why are we not screening for CMV? Okay. Why it is? Because CMV almost always, okay, gets killed in the process of pasteurization. Okay. And it unnecessarily adds cost when we start doing CMV screening also. That's the reason we do not do. We follow the NICE and Hambana guidelines. And registration and donation, donors are registered and they're educated regarding the hygiene, breast care, milk expression and handling and storage, and sterilization of the breast pumps. And set of labeled bottles are given to the mother. 5 sets of 5 bottles are sent to the mother's home, 200 ml each, and then they can be lended breast pump also if they don't have it, so that they can start expressing and store it in those containers. Once she takes one container, she has to fill the milk. With each expression, she can put it in the fridge. After 24 hours, once 24 hours are over, seal it and then put it in the back of the freezer with the date and time. So up to 24 hours, you can keep topping it up in the fridge. And after that, it is advisable to store it in the back of the freezer. Then take the next bottle next day and start pumping. So between the pumping, keep the milk bottle in the fridge. Okay. That is how it is. So, and donor expression freezes in the deep freezer. So once the 5 bottles are over, they call us, and then our runner will go and pick up these frozen milk in the cool bag to maintain the temperature, and they bring and put it in the freezer in the human milk bank. So what is the pasteurization process? I told you frozen milk is thawed overnight and pulled into a sterile container under laminar flow and put in about smaller bottles, about 130 ml bottles, and they're completely sealed, okay, to get a good seal before we do the pasteurization. In the pasteurization machine there, we have both hot compartment, cold compartment. So in the hot compartment, we do it in the holder method, 62.5 degrees for 30 minutes. And after that, it's transferred to the colder compartment and cooled immediately. Soon after that, we take one sample bottle from each batch and take a culture, and we send the cultures, milk cultures. After that, we freeze it again in the freezer. And we have a color coding system. When initially the mother's, when the mother's milk is given initially, so the reports are negative. then we will put actually red sticker. Once the milk is pasteurized, but we are waiting for the culture report, we put a yellow sticker. Once we get the cultures back and culture is negative, then we put a green sticker. So when you see in the previous slides, the green stickers means the cultures are negative and it is fit to be dispensed. Okay, that's how color coded system we have. So culture sterile bottles are ready to be dispensed, and we need a prescription from a neonatologist before we dispense that. And culture negative frozen bottles are dispensed after getting the prescription, and we get regular feedbacks from the recipients to make sure that we have a quality checks. And what are the babies who receive donor milk? Donor milk is not for every baby. Okay, so it is like a liquid gold. It is very precious. So we reserve it for extreme premature babies, less than 32 weeks and less than 1,500 grams, or any baby severe IUGR, less than 3rd centile or less than 10 centile in weight, but antenatal shows a reversal absent end-diastolic flow. And any baby with necrotic enterocolitis and post-GI surgery during the initiation of the feedings, a severe food intolerance, severe cow's milk protein intolerance, even in bigger babies. Sometimes we do give. Sick neonates during initial stages of starting feeds. We do not issue donor milk for term babies, for surrogate babies, and for babies at home whose mothers are not lactating, and for preterm mothers who have been discharged home, because it can get misused, because there are some commercial milk banks which are actually selling 10 times the cost what we are actually giving. So in fact, we give free for all the government hospitals and charge only 2 rupees 30 paise per ml for private hospitals. And if you give it home, then this milk can be misused by those people. Okay, that's the reason we don't give it home. And for preterm babies in the hospital without doctor's request, okay, we don't give it. So far, our experience is that, so we had about 220 donors who donated the milk, and we had about 553 preterm recipients. And look at the staggering amount of milk that we collected. 11,40,895 ml from 220 mothers. That's what I told. Yield from each mother is huge when you get collection at the comfort of their home, because mother keeps pumping every day, and all you have to do is once in 5 days go and collect the milk. Okay, if you only wait for the mother to come to the hospital and donate, how many times she will come in a month? Maybe 2-3 times. How much milk you will get? Hardly anything. And you have to screen those mothers, and it's a hassle, and it's not really worth doing for such a small amount, right? So look at that staggering number. 220 mothers have donated 11,40,000 ml, okay, of which almost 10,77,000 ml has been dispensed, and dispensed to 53 NICUs in Bangalore. When we started, it is we initially first 3 months was a struggle. We had to convince all these NICUs to please change the practice, and from the preterm formula, please go for donor milk. So culture change had to be done. A lot of effort have been put to do that. So now we have reached 53, and many times we have demand, the out supplies actually, the demand is more than the supply. Many times we may have to refuse milk because we don't have enough milk. So looking at the statistics of these premature babies according to weight, so majority of them are between 500,000 grams and also 1,000 to 1,500 grams, and very few of them above 1,500 grams. So what are the challenges of setting up a human milk bank? Before anyone thinks about setting up a human milk bank, we should always look at these challenges. What are they? Acceptability. So when we started in 2017, there was no human milk bank in Karnataka. So it was very difficult to convince people to start using donor milk. So acceptability was a challenge. And we had to make a culture change. At that time, all the neonatal units, if the mother milk is not available, they used to give preterm formula. All of them, because there is no other option. And we had to completely do a culture change to donor milk. So that was a challenge. So that is one challenge that anybody wants to set up a human milk bank, we need to think about how to bring about this culture change. And lack of knowledge among healthcare professionals about human milk bank, about even the pediatricians, obstetricians, lactation consultants, and definitely lack of knowledge for the public about human milk bank. And public awareness, very few. At the time, Karnataka public did not know about human milk bank. Since it comes in now, majority of the people know because they see lots of articles, lots of TV interviews. They keep reading that very, very regularly. So now the culture change has happened since 2017 when we started Amara. So it's a huge culture change now. And cost involved. Cost is quite high for setting up a human milk bank. So it needs definitely some funds to be mobilized, either through the government or through the NGOs, okay? So that we don't keep the cost of the milk very high. See, if a corporate hospital invests this much of money in setting up a human milk bank, they will charge a bomb for each ml, right? Instead of charging 2 rupees 30 paise, they will charge 30 rupees per ml to cover the cost of the equipment, right? And it doesn't serve any purpose. Nobody will be able to buy that much expensive, so they'll go to use formula feeds, right? So that's why we have to keep the cost to nominal minimal so that we encourage more and more. That's what we did. That's what we were able to produce a supply to 53 NICUs in Bangalore, okay? So that was a staggering number. We were able to do that by keeping the cost very minimal. And maintenance costs, you need to reserve yourself for maintenance costs. The 2 rupees 30 paise that we are collecting is only for the maintenance actually, because otherwise there was a cost. We were only paying salary of one nurse and one runner. And my services are absolutely free from 2017. Not a single penny has been taken, okay? So that is how we were able to make it so affordable. And we need to do regular audits to make sure that how we are doing, okay? Quality compliance. So these are all the challenges. So what did we do? To bring about a culture change, we conducted CMEs of neonatologists, CMEs of obstetricians, CMEs of lactation consultants. We invited all the specialists. We sent out invitations for all the neonatologists for a neonatal CME, all the obstetricians for a different CME, all the lactation consultants for another CME. We did all that to bring about awareness about the human milk bank when we started. So now it is much easier. Which are the milk banks now coming up? They don't have to do that much because the people are already aware about it. When we started, it was new, so we had to do that. And we did a lot of workshops, conducted workshops for doctors and nurses. We invited even donor mothers and recipient mothers to come and share their experience. So donor mothers interacted with the recipient mothers, okay? And they shared their experience. That is one of the donor mother who has come here with the baby. And the bottom, we have a recipient mother. She's a mother of a triplet. She's a doctor, okay? So she came and shared their opinions. And a lot of media coverage. It was important for us to educate the public. So many TV interviews, a lot of articles have been written. So media coverage was very extensive, okay? So you put Google now, Human Milk Bank, Bangalore, you will see all the results. Previously it was nobody knew about it. Now many people actually just put it in the Google, then you'll get all these articles which are there and links. And this is, sorry? Yes, ma'am, I'm moving. Actually, my talk was for 1 hour, but I'll cut it short, ma'am. So this is triplets mothers, okay? they 30-week at triplets, now 2.5 years, they're doing extremely well. And we had some celebrities coming and endorsing our milk bank. So that's also helpful. So to get publicity. And we have written few articles, like one like this in the liquid gold, okay? And I'm going to show a short video. Can you please switch on the this thing? Click on the video. Click it. Just 30 seconds video. Click on the picture. Yellapa. Gold on. Okay. 1 minute. Huh? It's not coming. No, it's a video actually. Okay. Videos are not playing. Okay, fine. Okay, so the videos are not playing. It's okay. I'll just skip. So I was about to show the short 30 seconds video of how the collection happens, how the storage. Then later on, when we have time, then I will show these videos. They're very, very useful. And this is actually one of our donors who is actually was doing DM neurology in Vaidehi Medical College. She's one of the mothers who are very passionate about donating milk. She came from Visakhapatnam, and she found out that she had already stored 3 liters of milk. And when she got a DM seat here, she did not want to throw that milk. And she found in research how she can transport that milk. And she got the dried ice, and in a different container, she transported that milk to Bangalore. As soon as she came to Bangalore, she gave me a ring saying that I got the milk and I would like to donate. And she is one of the, and between her shifts in the hospital, she used to pump and store it and then donate it to our milk bank. Very passionate donors. And this was our milk bank. I was about to show the video. I will do that later on. Okay. So this is also how the pooling happens under the laminar flow. These are some of the pictures from our milk bank. And you can see the label printer. You can see the temperature minus 23 degrees there in the deep freezer, and the milk collector from the donations. One before the pasteurization, one is after the pasteurization. You can see the green sticker. That means that baby is ready. That is ready to go. Those are the equipments. These are the BPA-free bottles that we use for pasteurization and dispensing. So what are the way forward? So we need establishment of more and more human milk banks. The reason is India has highest number of preterm babies in the world, and it has got high mortality rate still for the preterm babies, and nothing better than mom's own milk. The next best option is donor milk, especially in the initial stages of establishing feeding. Okay, thank you very much.
Thank you so much, sir. It was very informative. Now we welcome our next speaker, Dr. Asha Benakappa, HOD of Pediatrics, former professor and head of the Department of Pediatrics, Bangalore Medical College and Research Institute. We hereby welcome you, ma'am. Thank you.
Thank you very much. Finally, I competed with the commercialization of the natural milk a mother secretes for a baby. I call it as Amruta, and it is an elixir. Okay. And it was fascinating to listen to Dr. Sumana Rao, who's a WHO consultant, and KMC. KMC is high on evidence and very low on implementation. Have been in the field of breast milk and working in breastfeeding for the past 36 years. I believe in universalization of breast milk, and all mothers secrete 386 liters of breast milk in the first 2 years of a baby's life. Okay. So we were looking at all those PowerPoints there, and you in between you got something which said unstable. You know, something is unstable. So I just want to break the monotonous commercialized product of human milk banking. I'm sorry for all those people who are here, have been very, very vocal about it, have been fighting against it to a certain extent. As far as India is concerned, we have 92 human milk banks and 700 special newborn units. And recently we had an international conference where one of the speakers who has spent 20 years on human milk bank said she's very worried about it. Dr. Sandhya Katse, please have a look at it. So much so, the human milk banking has been drummed into your head in years that there seems to be no other alternative. And the mothers themselves will say, I don't want to give milk anyway, it is available in the bank. So please, you're all youngsters, I want you to learn the natural process of breast milk, and send me any mother who doesn't have milk. I'll make the milk come. Okay. And there's something called unstable. We were reading about it, unstable. I just want to share a joke. Today's mothers, we are all Google doctors. There's so many things that is happening with Google. And this mother, when the ultrasonologist reported the report as unstable, then the father went and told the gynecologist, for heaven's sake, if my baby is so unstable in the womb, what will happen when he's born? For heaven's sake, terminate the pregnancy. Okay. So that's how things are happening. And as far as I'm concerned, I own and run a helpline, which is called as Lactation Helpline, one of its kind in the country, and I got lots of awards for that. Whatever said and done, I want to emphasize. Next one. Can anybody tell me the cost of setting up a human milk bank? Yeah. Whenever, can anybody tell me the cost? You all read about the very complexities and the logistics and everything Dr. Manikanti explained to you. Can somebody tell me what is the cost of setting up and what is the recurring cost of human milk banks? You heard, no? He was telling you so much. That's all. Yeah. So unless you have that much money, you can't set it up. So you better learn the things from me. I'll tell you how to make it. Okay. Next one. Next one. Okay. Breastfeeding is an essential component. And I'm very sorry. My talk in the morning was communicated to me last minute. So I was not the speaker, but anyway, I'm sorry that it was not because of me. I was not there. Okay. Anything we have anyway group discussion, then we can talk about it. Breastfeeding is an essential component in congruent mother care, milk expression, and feeding of low birth weight babies. Starting now, the terminology is no longer KMC, it is congruent care. Because when we say mother, we were saying perinatal mother to child transmission of HIV, and then we had a lot of issues. The mother was victimized. Okay. Now in kangaroo care, anybody can do the kangaroo care. Even an older sibling can do it for us. And it can save up to 150,000 more lives each year, because we have so much of low birth weight babies, 30% as per the recent statistics. It varies from 25 to 30%. And IKMC is a new terminology. It is immediate KMC, skin to skin contact is feasible for every preterm infants, but thermal control remains a challenge. Next one. Zero separation. You're all very good in Googling and all that. Please look at Niels Bregman's this one articles on zero separation. I met him and he's too good. He never believes in separating the baby. The science behind the concept of skin to skin contact at birth and suckling expression should start very early. Okay, it's useful for transition of the baby from in utero to ex utero life, regulation of all the vitals, breastfeeding, microbiota. Microbiota is becoming a big thing now. We are talking a lot about epigenetics, bonding, sensitization. Separation of the baby causes harm. All neonatologists must do this instead of thinking alternatives. Next one. What happens when the baby is separated? There is maternal insensitivity to cues, maternal oxytocin receptor dysfunction, maternal depression, neonatal cortisol receptors decrease. The child is not able to handle stress anymore. Neonatal limbic brain loss resilience, neonatal feeding problem, developmental origin of health and disease. If you have separated the mother and the baby. Next one. Then the ability to breastfeed, remember, is innate. The physical capacity to breastfeed may, however, be insufficient in premature babies. Physical capacity. I'm not saying the mother is not secreting milk. Pleasurable feeding and sleeping is a beautiful physiological rhythm for premature infants. Sleep cycling is 50 to 70 minutes, and rhythmicity of the fetal stomach is 40 to 50 minutes. I really don't want to bore you people. You know what happened? I mean, one simple example I want to tell you. The milk ejection reflex. When the mother ejects the milk, there is 20 ml of milk that is produced. And if for one feed, there is 60 ml. And whenever a baby is sucking at the breast, some books say in 1 minute, the baby sucks for 45 sucks, and some books say 60 sucks. My quote, unquote, Ruth Lawrence breastfeeding. And, you know, so fascinating. When the 20 ml of milk is in the esophagus, the 20 ml of milk is in the stomach, and the 20 ml of milk is in the duodenum. So breast milk is continuously produced, and it is a continuous feeding that is happening. And it's a beautiful lining to the entire gastrointestinal system and lifelong. And you know what happens? The sleep cycling, everything is happening automatically. And the separated babies have become criminals in future life. You know, those of you who have fond of reading books, I want all of you to read the book, The Men Who Rape. I feel very bad when people say the men who rape should be guillotined. Why did they rape? When you look at it, it is, you know, they were never breastfed. They saw their mother, violence and things like that. Next one. Human milk and other milk nutrient composition. You know, nature, the one who's, creator, God, whatever, you know, I'm not a believer in God. Creator, when he created a preemie, there is preemie milk with lots of proteins, lots of immunoglobulins, lots of antibodies. Then there is colostrum, the first milk, which should never be missed. It's not available in the human milk banks. And then you have the term milk, and then you have the formula milk. It's worthwhile. This is not available in any books. I don't mind if you take a screenshot to know the difference. Then only you'll know how each thing hampers. And for each feed, depending on the emotions of the child, the milk is secreted. Whenever we are talking about formula milk, we are saying it is the same taste, the same thing. The child gets fed up. What I challenge you people to eat idli in the morning every day for the next 10 years or next 2 years. How will you feel? When you're giving the formula milk, it is something like that, but the baby gets frustrated. The same thing is happening with the donor human milk. We don't know, because it's if the child is fidgety, if the child is restless, the satiety factors come in the human milk. If the child wants to sleep, then leptin gets into the human milk. We do not have like that in the in the commercialized milk banks. Next one. The next thing is lactogenesis. It's a beautiful phenomenon. The transition from pregnancy to lactation, onset of milk secretion in early pregnancy to full lactation after parturition. Stage 1 starts at 16 to 20 weeks, occurs during mid-pregnancy, and secretion is held back by progesterone and estrogen. Look at these hormones. Progesterone and estrogen are pregnancy hormones. Prolactin and oxytocin are lactation hormones. They're both fighting. You know, though there is milk in the breast, the progesterone is not letting it come out because it's very possessive about the mother's obstetric related issues. Okay, that's why you cannot see the milk. And stage 2 is the onset of copious milk secretion associated with parturition. The progesterone level decreases during the first 4 days of birth, accompanied by a programmed transformation of the mammary epithelium, which leads to transfer to the infant 500 to 750 ml per day on day 5 of postpartum. We are not having patience for the progesterone to get out of the baby. You know, you talk about an NADIO and you talk about the peak. So the NADIO happens on the 3rd day. During that first 3 days, you do have some secretions, which is sufficient food and fluid for the baby. Before the baby is sent out, there is everything that is prepared in the womb, knowing this physiological status. Then stage 3 is the maintenance of copious mature milk. Earlier, we were saying autocrine and local control. Now, the latest pediatric clinics of North America, 2000, that's the latest one which came in 2013 says no such autocrine and local control. I don't want anything to happen to this unstable thing. Okay, next one. These are the stages of lactogenesis. If there are any postgraduates here, what happens 16 to 20 weeks, the progesterone level you saw, it comes down at 30 to 40 hours after birth, and then it is the prolactin and lactogenesis 3. Next one. So milk expression is the best way to remove milk from your breast is by feeding your baby. That's the best way. We cannot do that at all. Okay. And milk expression is removal of breast milk from a mother's breast without an infant's mouth at a nipple. Am I clear with these definitions? Next one. So situations for breast milk expression. Number one situation is a premature baby. Second situation is a low birth weight baby. Third situation is a baby in an ICU. Fourth situation is a mother who's working, then breast engorgement. So many situations. I would like to focus on low birth weight preterm babies and the NICU babies. Next one. So methods of milk expression, mothers get more milk if they expressed in the first hour. Remember this, therefore zero separation. Start expression right there, especially the colostrum. I'm very fond of Dr. Hima Bindu, who was recently contested the elections and lost the election. She is very, very particular about premarital counseling. Okay, and then marital counseling. So in breastfeeding, if a woman has to do breastfeeding, we need immense counseling in the antenatal period, because postnatally you have too many invaders who will come and tell you don't have enough milk, why don't you get this, go to that bank and get the milk and all that. I was really shocked when Sandhya Katse told me that in one center the mothers are reluctant to breastfeed because the milk is easily available. We are setting in a trend of laziness among the mothers, biological mothers. And then hand expression, also called as manual expression. Hand expression is when a mother uses her hands to exert pressure on a breast for milk expression. Any situation you can tell me, I can teach you. Next one. So breast pumping, you have different pumps, electrical pump and hand pump. And the previous speaker told us about the different pumps and all that. And imagine these pumps are dependent on electricity failure. And what happens, with such an unstable electric supply and all that. I am a proponent of manual expression by the mother's own hands, and we rely only on ourselves rather than technology. And then hand pumping combined, there are different discussions on this simultaneous hand pumping expression and all that. Remember, it's not one fit for all sizes. Okay, the breast pump, I've seen women who come to me who have done all this manual expression, almost the areola is ripping off because the phalanges, the fixing, everything, you need to have proper attachments. So I had written an article recently in one of the souvenirs that there are too many interfaces between the mother and the breast. And one such interface is breast pumps. In the NICUs, you have the interface of a lactation counselor, consultant who's not much qualified. Then you have the breast pumps, then you have galactocogs. Day by day, the interfaces are increasing as far as the mother is concerned. Next one. Though stimulating the prolactin reflex, mothers may stimulate nipple and areola to help in prolactin secretion. It's a very nice method of doing it. And then gentle stroke on breast, etc. So you can very easily stimulate the prolactin reflex. Many a time when you're doing it, the best thing is when the baby is in the NICU, they get really disturbed. So we have to do intense listening, learning, counseling skills, building confidence, and giving support. And putting the baby's photograph in front of it, listening to the baby's voice, the prolactin and oxytocin works magical. Okay, my majority of my clientele are working mothers, and this is what I do for them. Next one. And these are very methodical steps in stimulating the oxytocin reflex. One simple example of the oxytocin reflex: when you hold the baby like this, and when you're feeding, it is the interscapular area where the largest number of oxytocin receptors are available. That's why when I'm holding the baby like this, my forearm is touching the interscapular area and stimulating the oxytocin reflex. Even if I'm doing the cross cradle, all the time I'm focusing here, not on the head or the neck, but only in premature babies, we say support the head a little bit. Whenever you hug somebody, please don't hug now, because we're very, very scared of the Omicron, and somebody has given a complaint to the government. Anytime we may get a squad and ask us to vacate this place. Okay. So whenever we hug anybody, we are supposed to, do this. When you're doing that, you're actually stimulating the oxytocin reflex, which is also called as the cuddle hormone, the happy hormone. It's found numerous uses, in the latest books if you read. Next one. Then how to prepare a container for express breast milk. Dr. Manikanti told everything about the human milk banking. Same thing works. It is ordinary plastic at home. Okay, no such fancy containers. So I'll not repeat all that. Next one. Then storage of breast milk. Again, you had an exhaustive session on that. Simplest, there are many ways of storing milk. But as far as this session is concerned, I'm talking only about 24-hour storage. At room temperature, it is 8 hours, but we will want to be safer. So it's 6 hours. In refrigerator, it is 24 hours. Next one. So breastfeeding low birth weight babies, babies who are born before term, who are preterm and full term SGA. So as for the statistics, it's 30% of babies in India are low birth weight. As an ambassador of health, I would like to concentrate on prevention of prematurity. November 17th is celebrated as the World Premature Day. So let's concentrate on preventing prematurity by ensuring that all mothers, 75% of pregnant women in India are anemic, that we give them iron, we take care of their health. While I was preparing for this talk, I came across a fascinating piece of information, which I seem to have skipped while reading. How long do you give calcium to the mothers, prenatally and postnatally? Yeah. Okay, anything else? Any other reason? It's because of the progesterone. Okay, you must give postnatally calcium till the menses start. As long as there is no progesterone in your system, you're likely to have osteoporosis. Earlier, we were thinking that giving calcium to the mothers postnatally helps in the calcium level of the baby, but it no longer not related to that at all. All the time, the calcium and iron supplements you're giving is for the health of the mother. Okay, so till the menses return, now the recommendation is 180 days. Very good, somebody said. Now they are thinking of vitamin D3 supplementation to be increased from 400 to 800 international units. Next one. So breastfeeding and low birth weight babies, we know all the benefits. It prevents hypothermia, hypoglycemia, protects from sepsis, etc. I don't know whether Suman told you the lactating breast of a woman. What is the temperature of the lactating breast of a woman? Next time when you do postnatal rounds, take a digital thermometer or the probe from the incubator on the radiant warmer and check the temperature of the lactating breast. Anybody? Anybody? I got a chocolate today. Anybody says, I'll give them a chocolate. What is the temperature of the lactating breast? And that's how it prevents hypothermia. 38 degrees centigrade. Okay, the temperature in the uterus, the amniotic fluid is 38 degrees centigrade. Okay, sometimes there is, Niels Bregman describes it as thermal synchrony and asynchrony. The temperature will be so much the child will wriggle out. Okay, so it prevents hypothermia, hypoglycemia, and protects from sepsis because of all those factors, optimizes growth and development, reduces mortality. Preterm babies have difficulties initially, inability to coordinate, suck, swallow, breathing, immature and sluggish gut, and systemic illness. Next one. So what is optimal feeding of low birth weight babies? This is a favorite question in all your DNB, DCH, etc. Defined as adherence to standard recommendations, such as initiating breastfeeding within 1 hour, giving colostrum, exclusive breastfeeding for 6 months, and introduction of safe, nutritious, and age-appropriate. I would like to add one more: homemade, fresh, complementary food after completion of 6 months and good breastfeeding skills. Next one. So full-term SGA infants, because of being weak or sick, may also experience poor attachment and sucking effort on the breast, poor swallowing, they get tired out very fast, vomiting, regurgitation, etc. We have that physiological GER. Infants not stable enough to tolerate enteral feeds provided with IV fluids till such time enteral feeding can be established optimally. Direct breastfeeding from the mother's breast may not be possible or may not be enough to fulfill the need in many others. And in this situation, feeding provided by alternate feeding methods, not direct breastfeeding. We're talking about feeding tube, spoon, or palada or cup. Next one. So this is a method of providing fluids and feeds for low birth weight infants. This is available in the KMC and feeding of low birth weight babies in National Health Mission. You can download this document and go into that column. I really don't want to bore you with all those algorithms. Next one. So these are fluid requirements for infants. You are all very familiar with that. I would rather start IV fluids for the very low birth weight and premature babies than shift over to breastfeeding from the mother's own milk. Next one. Then these are the supplements that have to be given. That's why I said when we said the last 100 days, for the breast, antenatally, you're giving calcium for the pregnant woman, because in utero, all this is transferred to the baby. The baby is taking 750 ml of amniotic fluid every day. And through that, through the placenta, is getting all his nutrients. If he comes out a little early, we have to supplement all this. This is again from that document. Next one. So principles of advancing feeding modes. So this is from infant on OG tube. Then you can directly go for spoon, pallada, then direct express breast milk and direct breastfeeding. Next one. So methods of feeding of low birth weights. These are the different methods available. Next one. And how to do expression of breast milk. Deliberately, I did not bring the video because in most of the conferences, these videos never open. I don't know why. The conferences seem to be jinxed or they seem to be hating us. I have lots of videos of 700-gram babies who are directly cup feeding, expression of breastfeeding, twin feeding, etc. So, I mean, these things are available. So this is the method. This is called as the Marmot method of manual expression of breast milk. I have so many mothers who are so comfortable with doing this technique till the baby starts direct breastfeeding. Next one. So this is adequate weight gain. We know we should always be aware of adequate weight gain. In the recent conference, we got into an argument that the baby loses weight, things like that. Okay. So you must meticulously follow for 2 weeks. Okay. For all the small premature low birth weight babies, because there are some situations where there will be, mother will have milk, but it can be a low milk transfer. And mother will intermittently get into stress, depression and all that. So her milk supply will dwindle. Therefore, if you have learned how to breastfeed, I mean, if you learn confidence skills, in our infant and young child feeding course, we spend nearly 4 days on counseling skills. Okay, next one. So I would like to end by saying the new terminologies that we have coined. Breastfeeding should start early, 0 separation, so that the baby gets colostrum. It should be effective. Okay. It should be exclusive, absolutely nothing for the first 6 months. Now, in a big way, the microbiota theory is coming up. I'm really fond of microbiomes, and then it should be extended. Please ensure that it takes up to 2 years, because you know that the brain is developing. Only 25% of the brain development happens in utero, and the rest of the brain, 85%, happens at the 30 years. And the best man-made vitamins, nutrients, growth factors are in the human milk, and up to such thing. And the 4 N's are nurse the baby, nourish the baby, nurture the baby, and it should all be natural. This was what was the theme of the International Conference on Human Milk Banking. Thank you very much. If there are any questions, let me answer them.
Any questions?
I ended up stating that Dr. Asha Venkappa's institute, and she's a director sitting there, and we have a request for the human milk. So I just bounced to the NICU, caught out of the guy and said, what the hell? And he said, no, madam, you're too busy. I said, nothing doing. And believe it or not, I'm telling you, Manoj, believe it or not, where there's a will, there is a way. Every day in the director chamber, this mother, I have a photograph of her in one of her PPTs. She used to come to my chamber. I used to sit and counsel her. She had lost maybe 4 or 5 babies. And this was the baby which mattered. And if this baby did not survive, it was a male baby, she was going to be left. Okay. And every day we would sit and talk in the director's chamber at the far end of the room. The last conference, I met somebody and she said, madam, when I came to Indira Gandhi for something, I had pretty much made me sleep in your room. You know, that's a fascinating, it feels so good for me. And then I took her there, and believe it or not, she was exclusive breastfed that baby. And my brother, Dr. Naveen Venkappa, who extended ICU, they used to keep the powder here and take it and give it, because I should not see. But this particular baby was exclusively breastfed, and now the baby is 4 or 5 years, doing very well on the individual coach. Nature has fascinating things. When we started the COVID pandemic, I was the one who cried, horse, please don't separate the babies. Subsequently, we realized that there is enough and sufficient antibodies against the COVID for the mother to breastfeeding should not be stopped in any situation. Same thing will happen with HIV. In 2005, I was in a global conference on HIV and breastfeeding. And my teacher was alive then, Professor Nirmala Casey. They were the two people who just went on the stage and said, please don't recommend no breastfeeding for Indian babies. And now what does the HIV situation say? We should breastfeed. Okay? Thank you very much. And then
Good afternoon, everybody. Warm greetings from Kerala. I feel honored to talk after the legend of essential neonatal care, Asha Madam, giving a passionate lecture on some of the things which we thought we know, but still we neglect. So I want to start the I actually lucky in the sense that my talk has already been covered by Srinath and plus Asha Madam. So like whatever I'm going to talk are going to be an overview of what you have just heard all this while. So it is probably breast milk banking. I would like to put it in the correct perspective. So to start with, let me just start from where Madam left off, this zero separation at birth. So the first hour of birth, initiation of breastfeeding in the first 1 hour of birth is something very, very important for all of us. If we ensure this, half your problems are over. Now, I was recently going through some of the recent research on why this has become so much important. And if you really go by the endocrine part of it, the hormones that you should be stimulating are the ones that were stimulated at this point, like the growth hormone and such TSH and all, thyroid hormone, etc. But actually what is happening, the moment the baby is born, you take the baby out, you put the baby to, warmer, then you give POC with another the vitamin K and things like all these are going to be stresses which are going to counter regulate this hormonal balance. And then the adrenocortical release is something which is very important. It's not anyway not not part of the syllabus. So why I just wanted to just bring your attention to the WHO position paper, which moving just like that. Okay, so which very clearly says that if you initiate breastfeeding in the first hour of life, is there I can operate it myself. The baby has 33% less chance of dying than if you initiate breastfeeding thereafter. after 1 hour, and then 200% less chance of dying if you initiate after 1 day. And imagine the plight of the small babies we take care of. I'm just really inspired by the story Madam just told after the lecture. Like, so these are the babies who come to us in the NICU, whom we take care right from the time they are born until they are ready to be shifted to mother's side. These babies, most of them are denied this benefit, and all the other, they face all the other complications that come with this. Please go on to the next slide. Do we really need, in this scenario, do we really need a breast milk bank? Now here, of course, the problem is that we live in a different world. Everything is not perfect. And when we fail to convince our obstetric colleagues, I hope there are no obstetric colleagues. If there is there, then it's a good thing. If we fail to convince our obstetric colleagues to initiate this motivating mothers from the time the mothers conceive, and then if you do not initiate this thought in the mother and then make them ready 100% to breastfeed when the baby is born, if you start talking to them after the baby is born, when they are themselves under stress with the pain and all, you start telling them at that time exclusive breastfeeding is the way to go, probably you are going to, I mean, you are not going to be 100% successful. So there are reasons why we are going to fail in such scenario. The only way we will succeed is by initiating this thought in the mother before conception. So it's moving on its own again. Okay. So I do not need any more reasons to convince you why you should give mothers on milk. But there are scenarios where we fail. And what does WHO say? When mothers on milk cannot be given, the next best alternative is donor milk. And in this scenario, you cannot just give what we are doing 10 years ago, take one mother's milk and give to another. We need to go through a process. And this is what breast milk banks do, pasteurized donor human milk. So I say this with some scientific very well aware of some literature coming in of the superiority of the formula over PDHM in the recent studies, which are not at out and which needs thorough scrutiny before we, I'm just talking pure science, which needs more scrutiny. Those of you are in the habit of, or rather who have listened to one of the series which we were hosting, Learn from the Legends, we had a talk by Professor Neena Modi from Imperial College London, where she referred to this. So let us skip that. That is something may come out of it in the future. PDHM and the quality, that they were just talking about PDHM quality versus the formulas. So preterm formula. So that is a different thing. What does WHO recommend? When mothers on milk is not available, PDHM. But unfortunately, we live in a very imperfect world. Pasteurized donor human milk is not available. Then the third or last alternative is formula. This is how the chart goes. So if you can ensure mothers on milk, and if not PDHM, then probably most of the problems. Please.
Good morning. One of the most important workshops I feel amongst all of the ones which are going on is this one on breastfeeding, KMC, and milk banking. I think all three are the most effective cost interventions, or cost effective and effort effective interventions to improve newborn outcome. We have doyens like Asha Benekappa here regarding breastfeeding, Manoj, then who has established 2 human milk banks, am I right? And is aiming for several in each of the district of Kerala. In Karnataka we have 2, right now? 3. So a time should come where every district of India should have a human milk bank. That's the only way to negate the onslaught of the formula milk. Because only when we can provide the alternative, we have more strength in pressing home the use of breast milk. Please remember, both our 1 hour breastfeeding within 1 hour and exclusive breastfeeding is just about 50%. So there's a lot of work to do, but sometimes this happens in healthcare facilities only. I think it's the WHO which said those babies who get formula milk, 87% of them get in the first 3 days. And where are they in the first 3 days? Is right under our care. So we have to make special efforts, not just jump into the easy option. Even the parents feel that's the easiest option, but it's our duty to say otherwise. So thanks very much for attending. Thank all the seniors and faculties who have taken time off and have come here, and all of them are passionate about their subject, and we have learned a lot from them. Thank you.
Because all the faculties just come forward for a small group photo. So we'll continue with that. Can we move on to the next slide? So we can prevent a big chunk of mortality and morbidity if you follow this advice. So breast milk, mother's own milk, when that is not available, the next best option, pasteurized on a human milk. Only when those two are not available, then you will not keep the baby nil hourly and create all the problems. Then you may go for the worst options available. Now, breast milk bank history has been elaborated by Srinath in a very, very detailed manner. I would like to point to the one aspect which he just mentioned at the end, the role of Brazil. Brazil is a country that showed us that 73% of the IMR could be, they published this, like 73% of the IMR could be reduced after they established breast milk bank. And it was probably Brazil still has the largest network of breast milk banks in the world. Asia's first milk bank, we all know, was established here in our country in Mumbai under the legend Professor Armida Fernandez, and then now still that is a great institution we all look forward to when we try to copy that model and try to establish our breast milk banks. Yeah. So now, what is the actual reality about breast milk bank? Even though there are 60 to 80 breast milk banks, this is a study taken, done actually 2 years ago to be precise, where they send out a questionnaire just to assess the, this is done by the IAP subspecialty. They wanted to know whether these banks do conform to norms. And of the survey which was sent across, actually 16 only participated in the survey, and from that we have some idea of what is the status we have. Majority of them function in the government sector, and the procedures are more followed in those centers, but probably the better breast milk banks in the private sector probably were not part of the study. There can be so many reasons, but then there are few points which I want you to realize. Dedicated technician, only half the breast milk bank did have. Lactation counseling and dedicated breast milk bank technician. These are two essential people when you establish a breast milk bank. The first person, just to make sure that maximum breast milk is collected, or the better aim would be to make sure that maximum mothers do direct breastfeeding. And the second one, to make sure that the process is followed properly. And how many lactation counselors are required depends on the number of deliveries you have, but only 6% met the number of lactation counselors they were supposed to have. So these are lacunas, challenges in the breast milk banking that we all propose to embody. And I should really congratulate NNF for giving this prime spot as in the form of a workshop, even though probably the interest will come later on. Probably we think we know everything about this, but then so that's probably why the numbers are thin. Please. I think skip to next. Okay, so now the concept of breast milk bank has been now integrated under the India Newborn Action Plan into this Government of India program called facility-based lactation management, which means that it is a process. You try breastfeeding, and when it fails, you go on to supply PDHM, and it's in a very systematic manner. The steps have been described. It's a 3-tier approach. You follow vertically 3-tier, horizontally also 3-tier. Next slide. So pregnant women during antenatal care, the first step is breastfeeding importance to be given. This is the first step they are going to follow. Then you will initiate breastfeeding in the first hour of life. This is the next step. And then later on, this concept is actually, on-demand feeding. So like that 2-hour or hypoglycemia scare and all these things should be done away with. Give only on-demand feed, especially in the term healthy neonates, which contribute the major chunk. So you don't need to really give feeds every 2 hours, 3 hours and all that, because now we know that a lower sugar levels in exclusively breastfed baby are still neuroprotective as compared to higher levels in a formula fed baby. Probably why there are a lot of reasons I don't want to discuss. Probably we can discuss later on. They're all pure academics. This thing, brain uses 2 types of fuel, glucose and the ketone pathway. And ketone pathway, you give breast milk, it contains most absorbable type of bioactive fat, which gets converted to this. So that is enough. And brain likes ketone feeds rather than glucose feeds. When that is not available, which is the case the moment you shut off placenta, that is the glucose suddenly supply goes off. That is why this whole problem happens. So probably if you provide an alternate pathway in the form of early breastfeeding, these babies, even at a lower blood sugar level, do not suffer brain injury. So there are various reasons why on-demand feeding concept has come. And whenever the mothers, definitely we don't live in a perfect age, and mothers do have problems these days, especially working mothers who have been initiated to this concept of breastfeeding after delivery. So the lactation will fail, has to fail. If it doesn't fail, if you're saying it doesn't fail, then you are not living in this world. So if it fails, let us attack the problem. So some of the solutions given are next. Kangaroo mother care, and then there are various other things which I am not going to discuss because my top, all have been, I think, discussed. Go on to next. When nothing is working, then provide donor human milk. Next. And how do we provide that? Next slide. You have lactation support centers. So this is where you get the breast. So ideally, each lactation support center should also be, that is provided at the 3rd level in the 3-tier system that I told, where you have breast milk bank. That is and lactation support center and breast milk bank are the same in the new concept. So about the process, this has been elaborately explained by Dr. Srinath. So I'm not going to deal. I'll just recapitulate, or rather give an overview of what he already said, just to revise your memory. You collect, you process, and you distribute. Next. Who can donate? Of course, he said that this again I can skip. There are areas where I am still in the learning curve. In Kerala, we never had, even though Kerala can boast of the only state which has a infant mortality rate, single-digit infant mortality rate, 6, as compared to Scandinavian countries. Until now, the Tamil Nadu has come as 10. So the other states are catching up. So with such a this thing, and Kerala did not achieve this by providing tertiary neonatal care. It is by other aspect, not non-health measures. So anyway, we will not discuss all that. So if you what I was trying to say was, Kerala never had a breast milk bank until this year. We have been, from 2013, we NNF in the our NNF colleagues in Kerala, we have been fighting for this, and recently this year only we established our first breast milk bank, and then we were fortunate to get one more. So 2 breast milk banks we have established, and I am still in the learning curve. I'm taking lessons from Srinath on certain aspect what you do. It's a learning curve when you start a breast milk bank, and it is always you should always analyze the results and go ahead. So areas where you can concentrate initially, the problem that I still face is the demand is more and supply of the mothers willing to donate are less. And I said, we have strict policy. We don't take breast milk if the mother is just coming. So commercialization, no, that is all of us know. We don't do that. If mother is not breastfeeding, and if you do not ensure that the baby is exclusively breastfed, and after that she donates, then only we take it. So there are various, but that it has to be like that. Reduce the number. I'm following his Amara model. Reduce the number of donors so that so many issues can be the thing, and then motivate this group. So areas where you can probably target a healthy lactating mothers in postnatal ward. This is where we now, probably we have succeeded quite a bit. Immunization clinics, we are still to succeed. This is the area where you can catch these mothers. And lactating staff for the hospitals. Fortunately, we got sizable amount of donation from this group. And the mothers who are unfortunate, lost the babies, probably this is another area where you can try. Next. And of course, this has been well explained by Dr. Srinath, so I will not touch this. So probably the recommendations are there everywhere, and then this has been shared in the group also, I think. So we'll skip this. Mastitis infection, alcohol consumption, coffee, live vaccine. These may be temporary disqualification for a short period. Vaccine, again, this period is again now being disputed. So if you take a live vaccine, not all vaccines, 3 months, and then transplant, blood transfusion, maybe 1 year is still being followed. Next. So the breast milk bank, straight away come to it. This has also been explained. So the components, infrastructure, we'll just discuss these 3 parts. Yeah. So the infrastructure, the recommendations are, I'll just mention whatever was not mentioned, and then we'll sum. So we have, where do we follow the guidelines? There are WABA guidelines. There are various guidelines available for you when you start establishing a breast milk bank. So in IYCF, India Young Child Feeding Group of IAP has set up some guidelines which are practical for most of us. You can adapt that, and then plus add on something from here and there, from legends like Srinath on this who have done it successfully, and then you can formulate your own protocol. So, but the recommendation, you should have a minimum of 250 square feet that anybody will have. No, it has to be more. Like most of us will have more than that. It should be as close to NIC as possible, because the vulnerable, the people who are initially needing it are going to be in the NICU, and the mothers who are most susceptible to what you say as a neonatologist say will be there. So probably that is why in the both sides, and then there has to be a separate expression room, and there should be these are areas where people don't concentrate. Probably these are areas, if you do not have a space infrastructure constraint, probably these are, and this is our breast milk bank which we established this year. Please go on to next. Equipments, this has been covered nicely, so I'll just skip that. Yeah, next. So these, of course, refrigerated, defreezer, pasteurizer breast pumps are mandatory. And of course, hot air oven or any other method, depends. It's in a hospital, so there are various other methods to get this done. And then milk analyzer is a luxury. I don't have. Next slide. Okay, milk expression, of course, this is one that is very attractive for all of us, but as madam was saying, manual expression is as effective. Only thing, you need to take the pain. There are various methods, so you should be aware of all the methods available for expressing breast milk. And it is that first of all, the mother has to be willing, and when she comes, make her comfortable in the separate room. As I said, mother has to be in a separate room. It can't be inside the breast milk bank. It can be in a separate room where the ambience is good. Mother is made to feel that, okay, I'm doing something very noble. I'm going to save a life. So that sort of feeling. So that is because the positive thoughts only will induce the letdown of this thing. I'm not saying to make them happy so that you get maximum milk. So, and in such scenario, you can use manual expression or mechanical pumps or electric pumps or the sophisticated pumps, which you can adjust the pressure at which the expression has to be done. You follow any method. I'm not a proponent of any of the, we have this, but then I'm not a proponent of this alone. We use all methods depending on the scenario. Please go. I'm not in the group. Huh? There is a, I'm not in the group. Huh? Sorry. Oh. I'll merge it. Done. I think you can space out and sit. You want to post the certificate in that group? Yes. Please hand me the group. Then I'll after this talk I'll do. Yeah, okay. Oh really? Can you send the? Okay. I already have it because I travel from Kerala. No, I already have it here in WhatsApp. Okay. They come, all of them. mine is done. Shall I? Yeah. So expression can be done by any of the methods, but expression has, you have to, madam has beautifully explained the physiology of how the whole drama, whole process evolves. So you need to be very sure that mother is very happy, the let down reflex is happening, and then make her comfortable and express. Next. I'll skip this. Next. Processing again has been beautifully explained. So whatever milk you get immediately, this is what we do, immediately refrigerate until serology results are available, and then we pasteurize it. Pre-pasteurization colony, we just do this thing. This is not mandatory. And then any colony count as per the recommendation, less than 10⁵ CFI, you throw away. And after pasteurization, you have to, that is mandatory, you need to do a microbiology and colony count. And here, make sure that you can do it in either way. If you have a lot of money, then each sample you can take separately, or you can do random sampling. The problem with random sampling is you take one sample from a group and then you send it. If it comes positive, the whole thing has to be thrown, but it doesn't usually happen. So probably more economical will be a random sampling. Next. Deep freezer, the temperature is -20. This is where I had some problem initially because there are various technical issues which we doctors are not aware, which also we need to learn little bit of physics also to get this right. And then ideally we should have 2 deep freezers. The vertical one is what we have, horizontal one is also okay, and one before and for one pasteurizer. So if you, whatever you collect, you keep, and then you take it for pass. After that, when you bring it, you don't keep in the same deep freezer, you keep in a different one. It has to be clearly labeled. Next one. Refrigerate also, 1 or at least 2. 2 because we are just we are having 2 because we are collecting it, you're storing it, we don't immediately pasteurize. So till then it has to be stored under refrigeration. Next. Hot air oven is an optional. There has to be some sterile service unit in your hospital, which all of us have. So this is one of the options you can for all the equipment that you use. You can use the ETO, whatever, depending on the equipments what you're using. The methods of pasteurization, since that was not dealt with in detail, I'll just a little bit of theory. You have now the concept of pasteurization has been under scrutiny for the various methods. You have a low temperature, long time pasteurization versus high temperature, short time pasteurization methods. So usually what we follow is the Holder's method, 62.5 degree for 30 minutes. So both will work. Actually, so people have been trying to look at which is the most cost-effective method, and then shaker water bath is what you can use if you are if you do that is a cheaper option. There are people who are against it, but then IYCF recommendation abroad, if you talk to some people, they will say that shaker water method is inferior, but then the IVCF recommendation you can still use it. It's a cheaper alternative when you don't have like the one, like from my personal experience, we got funding from Rotary. That's how we managed to get this thing. So 30 to 40 lakhs per bank you need to spend if you get everything for the whole thing to start going. Recurring expenditure is different. That of course the hospital has to provide or somebody else. So it's a costly affair if you want to do it systematically. And when you start a program, there will be so many people to criticize you. So when you start, please start it with all the following all the recommendations. Do not do stopgap arrangements, because one that may fail the program. We were very particular that when we started, because we didn't want in our state the program to fail, but it takes a lot of time. The learning curve is too and I can't say, it may be even straight at times. It is not going up. So probably the slope you will have to straighten it, or rather make it more steep. The methods, there are various methods. There is some research on ultraviolet this thing. Then if you some of you attended the online the hot topics recently in US, the trade section, they were showing some interesting equipments. I'm not sure whether those can be reality. Like you don't need a pasteurizer, just get milk, do that, and then give it. So it's, you don't need to have a bank then, if that comes. It's like an individual bank as an equipment. So there are various things. So the principle they all use is a high temperature, ultra short time, or ultraviolet, or mix of both and all that. So these are for the future. Please go ahead. Skip. Again, I think we can skip this. Now, storage, there are various guidelines. You can remember one of the IBCF recommendation, rule of 6. Freshly expressed milk, room temperature, keep for 6 hours, in the fridge for 6 days, and freezer for 6 months. So this is, freezer means it has to be a certified freezer, minus 20 degrees, and not in any freezer in your this thing. So this is probably what you can give. This is maximum. Okay. The probably, as madam said, 24 hours more than 6 days is what we prefer to keep in fridge. But then say up to 6 days, studies say that you can keep it. Once you thaw it for use, then probably it has to be used in room temperature within 4 hours, or if you want to keep it in fridge for a short duration, people say even up to 1 day. But this happens because when you have your breast milk bank, and then you don't have a breast milk bank, but you very badly need PDHM, you send to a nearby center or to a nearby town. So there is a time. So you need a cold chain for that, and you adopt this for this thing. So some refrigeration period for this will be required when you do this. And then once you thaw and warm it, then it has to be used immediately. There are below running lukewarm water, you need to gently agitate to make homogeneous mixture. Just remember, never use microwave. But it may, if you use microwave, what is going to happen? Again, the quality will again come down. The IGA component will come down, and never refreeze after thawing, because then there is a risk of all those triglycerides getting hydrolyzed and all that. Yes, this is a dream machine that probably you have already. Milk analyzer. Yeah. Probably, but it's not mandatory to set up a breast milk bank. Now, dispatch, ideally, who are the babies whose milk who should be given? So there are various questions. So like ideally preterm, if you can afford the luxury of having different sections in your breast milk bank, preterm milk. Milk. Like if you have this, then preterm milk is preferred for preterm babies. Otherwise, use whatever is available. This probably is a way to counter the emerging evidence that is coming in, where they looked at the PDHM versus formula, which I was alluding to previously. And transport has to be in cold chain. And one of the things that we need to be very, very careful when you start your own breast milk bank program is documentation. There are set guidelines available, set documents which need to be preserved. We live in an era where even the patients can turn hostile and all that. So for various reasons, we need to have a ideal documentation ready. Okay. Now these are all the classic studies where, of course, the mother's own milk was compared with PDHM. And of course, this basically Brazilian study, which is a major contributor to this. And so there is slight reduction in the component. And we know that MOM, if it's available, you should never use PDHM. If there is a chance of getting MOM also, never use PDHM to make the mother more comfortable. So these are issues probably you are aware of, but otherwise we know that MOM is slightly superior to PDHM. So I will just stop with this meeting the shortage. The mismatch between demand and supply is the first challenge that you're going to face when you start a breast milk bank, because there is a lot of demand. So we restrict it to the most eligible ones. The preterm babies who are in our policies, the level 3 care neonates who need to be initiated on nutrition on the day 1, the 24, 25, 26 week babies. And so the lower the gestation, they get more preference. And this is how if you have little amount, you give preference. And then the unfortunate babies who lost their mother and things like that. So probably that is a group where you cannot give it as an alternative to formula when lactation has failed, because so much of quantity is not there. The commercially prepared PDHM, I don't want to make a comment on that. I am not aware of any study that has really said it is equivalent to the PDHM that we are talking about here. Lack of awareness amongst pediatricians, us doctors as a community, as healthcare givers as a community, and amongst the parents. So these are issues where we need to really concentrate. Yeah. So we need to be ready. Mom is the right of every baby, term or preterm. If it might be impractical in extremely low birth weight babies, and in such cases, it is feasible to meet the challenge with PDHM. So probably the one bank in every district with peripheral collection distributor centers may be the way to go. This is my thoughts only. But then probably in resonating with the INAP, Indian Newborn Action Plan, where they have said the lactation management as they're taken it comprehensively. So the Apex Center for Lactation Management should have a breast milk bank. So probably. Okay, so I'll stop here. I'm ready to take questions. I'm sorry I've been given a work, so I'll have to leave after maybe by 2 o'clock or so. Questions I am ready to answer. There are set guidelines available for this. What I do, I'll tell you. And then it's worthwhile going in the IVCF. That is applicable pan India. They looked at the Indian scenario and then they made guidelines. So that probably falls good. So we just whatever we get is so precious for us. So whatever we get, we collect it, and then so what are we collecting individual bottles and keep in the separate. We have 2 fridges. So actually, so the one fridge you keep, and then when we have sufficient quantity, so twice or thrice a week we pasteurize. Just because I may be our center, we may not be having so much of. We get around 2 liters per day. That's all. So it may be very, very less as compared to talking about gallons. But don't get so much. Once you reach that, then probably yes. So that is why. So it depends on how you. So if you to answer your question, collect it, keep it in the freezer, and then when a sufficient number is there, what we do is we send a random sample. We just because it's kept in fridge also. There is no because pasteurization will kill all these. But still, we take a sample and then we send it for colony count, and then we pasteurize it. After pasteurization, mandatory to take a water. Depends on who is the mother. Like if it is your own mother who was delivered in your hospital, where all the tests have been done at the time of delivery. So only once. No, not again. Unless of course a new mother you got hold of in the immunization clinic, you don't know much. Then yes. So it has to be individualized. The question is practical question. I had 2-3 scenarios. The question is who will bear the cost? Obviously, you can't ask the mother. And then right now, we in Jubilee, we are just giving it free. For 2 years, we have some funding. Totally free, we are giving. After that, no, it won't last. We have to have a no profit, no loss system. So who will bear the fund? So if you unnecessarily add to protocols, unnecessary testing here, and then the cost will go up. That is the only thought. More tests you do, more maybe better. So, but mandatory after the thing colony count, and then basic screening the diseases. What is recommended also I just showed. Give money. You are not supposed to do it. No, we wanted to do this. Then I consulted so many people. So because we wanted to give them an appreciation, they done a noble time. You are not supposed to give them monetary benefits. What we do is we take their photograph. And then so the champion of make them feel good, and then the social media is the reward you can give them, because every day every parent is hooked on to social media now. So that probably something like that you have to have no monetary benefits. Yes, please, you are better qualified.
So basically we thought about it. So that disadvantage of incentivizing the mothers, what it has is, because there are some commercial human milk banks, they go to poorer sections of the society and they incentivize these mothers with monetary benefits. So what will happen if a mother is getting the money for donating the milk? Either she deprives her own baby of the milk, breast milk, and gives cow's milk to that baby and donate the breast milk to human milk bank. Or what she may do, she may express 500 ml of human milk and then add another 200 ml of cow's milk to get more money. Okay. So when you go to that route, it is when money is involved, especially in terms of donation, we can't assure the quality. Second thing, we'll deprive the same baby of breastfeeding. That is not what we want to do. It's a crime, right? So yes, as Dr. Manoj said, yes, give them a certificate, maybe appreciate them. Yes, they can get some mileage out of that. That is the best thing to do. And also when we conduct workshops where we invite both donors and recipients, then when the donors, when they meet, and so the donors feel so blessed that they give all the blessings to the donors that you have saved our babies. Although they may not know it's exactly the same donor, it is just a representative of donors and recipients, okay?
Dispensing the baby or to the recipient. Okay, I'll tell you the value model which I followed. Thing. No cost, no profit is what they do, because there is some charge involved in actually doing the tests and all that. That you can decide, but if you make it for profit, I am not saying it is not ethical. It may still be ethical. It is not. Nobody gives anything free. So that you need to in the what scenario you're working, it is the thing. But then probably as custodians of neonatal health and child health, we should have some moral responsibility. If at all you charge, I'm not saying we don't charge. I am my personal views you should not charge, but I am not saying it is not totally unethical to charge for the work that you do. It should be only that. The whatever expense you incur, test, and then some people can even know, like, because you need to maintain a staff for it, you need to run the equipment. So all those costs, if you add on a recurring basis, probably it may not be unethical. Okay, so I'll just yeah, yes, sir. Please go ahead. Of India's published. Yes, yes. And the government, I did not mention that, because then I did not want to go on that the thing actually. I actually showed the same thing in the picture. It is actually in the thing with the INAP recommendations and the thing. So there are guidelines available. What I said is what I followed was the IYCF guidelines, which are the thing. There are some differences in that, but essential principle what you discuss are all the same. Really, ma'am, I should do. Government institutions.
65 lakhs to start, only for government institutions, okay? Many of those which started, they gave 65 lakhs, but ongoing cost per month is 6.5 to 7.5 lakhs. They're not finding all these technicians, whatever Manoj said and whatever. This is a corporate donor. So the people who took the amount had a lot of issues with the logistics. So if there's a government lactation management guide is there on the NHM website.
I can explain to you why it was not successful, because in Manipur the same thing happened. They sanctioned 65 lakhs. How they, why the running costs come so high? They're appointing a director, they're appointing one manager, they're appointing one microbiologist. It is actually not at all required. How we were so successful in Namara is, we were only paying for one nurse and one runner.
No, Dr. Kanti, 65 lakhs is for starting the blood bank. No,
Who means the recurring expense?
Human resources, they don't give. That is hospital has to maintain.
Madam, that is why. Madam, that's why government has to learn how to run an human.
They're not paying microbiologist, data operator.
Why is the running cost so high now?
6 lakhs.
Why running cost is so high? No. Because that is completely mismanaged and a lot of unnecessary expenses are being done. I have been running the milk bank for 4 years. I know how much does it cost. Okay. So with bare minimum 50,000 rupees, we can run a milk bank. Okay. But provided you have the doctor's service completely free. You can't pay a doctor's salary into that. Doctors, microbiologists, or neonatologists, they should not be taking a single penny. It has to be voluntary. Otherwise, cost will go up. Yeah, you can pay one nurse, you can pay one this thing. The same thing now I'm setting up another milk, helping another milk bank in Mangalore. Dr. Baliga called me. How many staff we have to this thing? That time guidelines say you have to employ this one, you have to employ manager, you have to employ this. Why? There's no big work. We can train the nurse who can manage both the computers as well as the pasteurization, and she has to just send, and the runner has to come and collect it and distribute it. Anyway, it's set up in the hospital. Microbiologist is already there. Lab is already there. Neonatologist is already there. Or if they want any free service, I was happy to give them free advice. But still, they want to go and employ somebody and then pay 1 lakh or 1.5 lakh salary for every month. That will add cost. So that is counterproductive. We have to minimize the cost. Then only we are successful. Why we were so successful is because we minimize the cost. And we are giving free of cost for all the government hospitals. And private hospitals, we are charging only 2 rupees 30 paise per ml. That is nothing. That will cover our costs. I just said that. In government, ma'am, lot of burden is putting on about human resources. I think that they need to cut down. I'm no longer in the office. Yes.
Now, unfortunately, the government sector does not cater for the majority of the people who are taking treatment in, at least in our state and some other states. So when then of course, if government is providing healthcare to the majority, then probably this 65 lakhs should be better utilized. We should have a discussion on that. But if it's only a minuscule in this thing, then I don't know. I would stop here. With Sneha's permission, I want to invite all of you to Thrissur, Kerala, in the month of March, second week from 10 to 13, where we are hosting the National Conference of IAP Neonatology Chapter, IAP Neocon, along with the International Neonatology Summit by NNF Kerala. It's a 4-day event. I will distribute the brochures tomorrow to all of you. Please do come. And yes, I mean, yeah, no, there will be no scar. If such a scenario is there, then we will. So it's a twice postponed conference. It was supposed to happen in 2020, and then now it's being held on from 10th to 13th. Thank you so much. I'll just share the details in the group with your permission. Thank you. Thank you.
Lunchtime, ma'am. Till 1:30. Ma'am, after lunch, ma'am. So your talk? No, sir, then lunch. It is at
one discussion. See, panel discussion has to happen at 3:15 only.
Yes, sir.
Because there are international speakers who are joining, and there are speakers from
Hello, good afternoon, everybody. I won't take much of time. From morning, the legends of breastfeeding and their knowledge, they have shared so much that Dr. Suman Madam, Dr. Asha Benkappa sir, Dr. Srinath sir, Dr. Manoj sir, they have shared so much humorous knowledge about breastfeeding. My talk is totally something different. I want everyone to don't note down anything, don't write down anything. I won't tell anything much very difficult things, all very common things which we have encountered, not only me, everyone who have gone to postnatal rounds, when they see the babies, what they've seen in the family, what problems they face during the time of postnatal period or during the time of delivery or during the antenatal period. These problems I like to highlight, Anna. And I feel these things should be more enlightened in the future breastfeeding programs, telling. With permission of everyone, I like to start my talk. This is a list. These are the learning of which I'll be telling about benefits to the baby and benefits to the mother, and about the prolactin reflex and oxytocin reflex. Next slide. Next slide. Slide show. Next slide. Next slide. And breast milk and human colostrum, they are made. See that it goes away. That one. Side. They are made for the babies and is the best food. And easily digested and well absorbed and contains essential amino acids, and they are richer in fatty acids, and better bioavailability is present. And next slide. And they prevent under 5 child deaths and protects against the infection, and prevent allergies and better intelligence and promotes emotional bonding. And less heart disease and diabetes and lymphoma is known. These are the next 2 slides. I want everyone to concentrate because here you can see that when the mother is infected, the WBCs in the mother, the body makes the antibodies to protect the mother, and some WBCs they go to the breast and make the antibodies for them also, and the antibodies to mother's infection are secreted in the milk, where indirectly my baby is also protected. And the benefits to the mother, it helps in involution of the uterus and delays pregnancy. So these are the next slides. I'll just rush these slides. This is the most important slide, next 2 slides, which I'll be telling. And it is the oxytocin milk ejection reflex. The oxytocin, when they contract the myoepithelial cells, the milk is secreted, and the sensory impulse from the nipple to the brain, it's going, and the baby sucks. For this reflex to occur, there are 2 things. One is stimulation factors and the inhibition factors. Okay, the stimulation factors, you can see that which should be very much necessary for the mother, which should be present. So that is the thinking and loving on the baby, and the sound of the baby should be present, and the sight of the baby should be present, and the confidence to the mother should be present, which is very, very important, because my next slides will be telling how confidence and how important the mother's mindset should be there for breastfeeding. And there are some inhibitory factors also, that is worry for the mother. Worry can be different things. Which are those worries? I'll be telling in my next slides. And stress, which is again very important, where mother should not have stress. And pain or any doubt, these things should not be there. So these are the stimulating factors and the inhibiting factors. Keep this slide in your mind, each and every one of you all, and we'll go to my next slide. And for successful breastfeeding, a willing and motivated mother should be there, and an active and sucking newborn should be there. A motivator who can bring both mother and the newborn together should be there. And this is the important word I like to stress upon, the motivator word. And anyone can tell what is this slide tell about? Yeah. She is scratching the head. What to do? Breastfeeding. I'm not able to get the breast milk. It's very difficult. What to do? It is not at all so much difficult. That too, if you send to the Asha Bankap madam, it is just like chitki. Very easy. Madam will explain how easy things are. And same thing, the lady scratching her head due to the problems faced during the breastfeeding. And it is not so easy. It will be easy. And if at all the husband also gets more worried that she is not getting breast milk, and if he scratches his head, means he will become bald. Okay. So and it is not difficult or complicated. It is an art. Like any other art, it requires study, practice. It takes some effort for mother and babies to set into smooth breastfeeding. These are few 2-3 slides I think I've copied from Asha Benkappa madam. I have read madam book 15 years back itself. That time only I was impressed and made these slides long back. And this is again the slides with theoretical slide. I don't read more slides. Okay, but only this last line I like to tell. In present day nuclear families, the wife is required to discuss about the breastfeeding with her husband right from the time of pregnancy, so that she can ensure breastfeeding. Another thing that the husband has to do is to prove encouragement. This is the most important thing. This one, lady getting ready, means the person, husband, father, mother, or the husband and wife, they should start getting ready, not after the baby is born, for getting into very good exclusive breastfeeding. That should be before conception itself. The plan should be there, how to go on for breastfeeding, and how to bring about the babies taking care well in the future. And before conception, after conception, and after birth of the baby, how to take care. These are the points which I'll be discussing. And this is the one slide which tells that mother who is a pregnant lady, she is in the office, and the office is in the 4th floor. No lift is there, and many times the lift current goes away. It won't be working all well. So in that way, again, mother will start climbing. So that is again a stress coming there, and which should be relieved. And the office people, they should see that any pregnant ladies, the ground floor is provided for the working opportunities. So it will be very useful, and good care can be given to the mother. So if this is there, well, and next thing is in the office also, they should not give overload work, not during not pregnancy time. How much she can work, so much work should not be given. It should, the colleague should be very friendly in nature, and they should also help. This is again a very important point, and even this again helps during the breastfeeding time. She should be given time to go and feed the baby in between if it is nearby baby is there. And for even expressing the breast milk, the office colleagues and the office itself, they should be very much helpful for the mother for making her stress-free time. And sometimes you can see this, the husband is far away, mother is in India, or husband is in some other country, then again there will be difficulties. So understood, okay. So mother will be stressed here during breastfeeding. Again, breast milk is not coming. That time husband should see that he calls the wife and keeps talking about, inquiring about her difficulties, inquiring about how to solve the problems. And he should also inquire about how the things go on in the family, and how family members also is supporting the wife. These things should be inquired by the husband, which is very much helpful for giving the decreasing the stress in the mother. And this should not happen. There should not be any quarreling occurring during the, what I told before conception, after conception, and after the breastfeeding. There should not be quarreling within the family, which usually we see commonly occurring. Okay, so sometimes if you see that more quarreling, if it is there, then this can lead to even divorce also. So this again, it will be very difficult. And what happens, once I got one mother who is a software engineer, who came with the kid, 5-year kid. Okay, and she was putting in the earphones in the ears, and she was talking she was doing the office work even during the consultation time. I asked her, please remove that, and we'll talk about the child's condition for 2 minutes. So she started pulling it. She told, sorry doctor, we'll talk to you. And I asked, what is the child age? She told 5-year child. What is the complaint? Fever, cough, all these things she told. Okay, and pediatricians, they are very eager about asking the history taking. We write around 18 to 20 pages of history taking, and I think so no other department writes so much history taking. So we are very keen. And when it comes to the family history, I asked, please tell me the family history, whether you're joint family or nuclear family. She told, yeah, we are the joint family. Yeah, please note down. Joint family means usually we think, no, grandmother, grandfather, and all uncle, sister, everyone is, all are staying together. We thought like that. And I started writing down. Then she told joint family, please note, tell the how many members are there. Me, my husband, and my child. Only 3 of them. Nowadays, husband and wife staying together has become a joint family. Okay, because they'll be staying far away. Okay, not even see software people, they'll be working in Bangalore, one person, or in Hyderabad or Chennai, some husband will be working. So that should not happen. As much as possible, if convenience is there, let them stay together during the antenatal period and postnatal period, I'm telling. Okay, because my concentration here is about antenatal and the postnatal period, which is very, very important for the baby's sake. Mother has to feed well. For the mother to be more happy, she should be kept happy by the husband and the mother-in-law, father-in-law, all the house people. So that should be the environment which my concentration is more on that. And that will make her more happy, and even the helping doctor also. So, and in this way, she is again, when not that only, she should be taken care of. Even previously also, even when father is, our husband is sick, even he has to be given a good care. And even when he is sick, even she should help also. And in this way, helping each other, give and take policy should be there, and that will be of more helpful for the family. And even during the antenatal period, lot of pain will be there. And hyperemesis gravidae in first trimester, it's very difficult. They'll be scolding. Mothers, if you go to the antenatal, you ask many mothers, they'll tell so much difficulty it is. And they'll be getting vomiting. In front of that, husband will be eating biryani. So that is again more difficult. She'll feel more problem. So you should not do that. I should, okay, at least not in front of her during these periods, I just told. Okay, so that is very important. And next is even during the postnatal period, whatever she likes, the husband should get and give to her, and she see that the husband gives a good care to the mother. And if you see this picture, what I came to know is there was one mother, madam, one mother. She was seeing serial TV. Okay, and while seeing serial TV, suddenly the news people came. TV9, BTV or TV5, so many channels, news channels they came, and they hold around 10 people, they came together, and they hold a sudden census was done about the serial seeing mothers, how they react. So they came, this mother was seeing the serial, and suddenly they asked her question, whom do you like more? You are seeing the TV continuously, you like your husband more or a TV more? And she gave an answer telling that, no, I like both more. I like my husband also, my TV also. And all the news channels, they were very much surprised. What is this? This lady, she is answering that she likes more. How, madam, how do you like more? Yeah, I like both my husband also and TV also, because both remote are in my hands only. Okay, so in that way, so during the antenatal period and the postnatal period, stress will be there, and even she'll be having the lower limb pain will be there, back pain will be there, and heaviness will be there, headache will be there, giddiness will be there. All these problems will be there. See that the husband tries to help the mother, wife as much as possible, and keep her more happy and stress-free. Well, and they'll be becoming weight gain will be there for the during the antenatal or postnatal period, and which see that the husband doesn't go for any other affairs. All these things, chances are that should be avoided again, which will be more helpful. Okay. And for any father to give love, there is no any poor class or high class or middle class. Every father can give equal love to mother and the baby together, which is very important for the exclusive breastfeeding to be more good successful. Well, and this again weight. If you do exclusive breastfeeding, you'll become lean like this lady, or else if you don't do exclusive breastfeeding, you'll become you'll be weight gain. So you can decide whoever they want to be there. And this again, you should not upset your wife, husband. How things they upset is this again, when they do not talk some loose talks to the wife during the antenatal or postnatal period, or do not tell her that I'm going at this party or that party. See that you try to convince her and slowly, and see that you get her also things whichever she requires, and then go to the parties are, that will be more convinced for her. And you don't, sometimes you see that you don't upset your wife. One thing is, what I like to tell here is, there was this one, when I was small, around 9 to 10 years old, I had gone to a village once, and I used to throw stone to the curate or the pond. A river was there. So I used to throw that stone used to go pitch. It used to go pitch, and 3-4 pitch it used to go when you used to throw. I was around 8 to 10 years. And some old person, he came, he saw me that, he told that, see, my dear boy, you should not do that. It is very wrong. I told, what will happen? I'm hitting just a stone to the river and it is pitching and going. No. If you hit this stone to while going if the stone is going in the pitchwise in the river or in the pond, if it is accidentally hits the frog, then you will be getting the dumb wife, means she can't talk. So you will get such a wife. I got very afraid at that time. I stopped hitting stone from that time onwards. Okay. Now after marriage, 10 years over, now I thought I should have not listened to that person, senior person who told me this, because a lot of things, it will be very important and very difficult, but you can again get through all those things by just see that you keep listening to her, whatever she tells her, or don't get upset more during the antenatal period. She gives a lot of complaints also. Do not get upset and keep going with whatever the complaint she tells her, and try to solve as much as possible, and take the doctor's help, family doctor help, or the pediatrician help, or the obstetrician help during the antenatal obstetrician help, and postnatal period the pediatrician help or the neonatologist help. They will always be helpful. Helplines will be there. So those things should be taken care well. And during the antenatal period, you take her to the park also for walking. All these things, be with her during the walking, which is very much helpful for her and for her mindset also, to keep more free and more tension free or stress free. And do not get angry on wife whenever she gives complaint. And these are the different ways how they start giving complaint. Sometimes what happens that जो हंसता रहता है उसको हंसमुख कहते हैं, जो हंसता रहता है उसको हंसमुख कहते हैं, जो हंसना बंद किया उसको हस्बैंड कहते हैं. Okay, so the full form of husband is hasna band. So during the antenatal and postnatal period, I'm telling, and as much as in husband, actually there is something called bending is there. So if he keeps bending more, he is more comfortable in his family life also. Okay, so whatever he might be so much successful outside also, but he should be very silent in the home, which will make him more successful. I should, okay, to become success outside, you should be more bending or more soft inside the house. That is most important. Why I'm telling is, once one husband was there, and he was wearing this panche banyan, and he was reading the newspaper. Okay, it was 7:30. The wife came with 1 cup of glass of coffee, and she gave coffee, and she told, please, my dear husband, please give me the newspaper. I want it for 5 minutes. The husband was a CA chartered accountant, very well studied, and he was a double graduate, but she is not studied. She is just in high school. He started scolding her. What is this? You are my wife. You are a double graduate chartered accountant in the city, the famous chartered accountant wife. You should not read newspaper. Nowadays, the things have gone very forward. So you have Apple laptop is there, Apple iPad is there, and Apple phones are there. You please use these things. Don't use this nonsense newspapers also. She told, no, it's okay. Newspaper is enough for me. Please give me. He didn't listen. You do not know. You are just studied only high school, and you want only you go improve, and you take this my iPad. He told. Then she went inside for the kitchen. So later, after 5 minutes, a big sound came. I said, okay. So after that, he ran to the kitchen and he saw what happened. Then he saw that she asked for the newspaper to hit the cockroach. I said, okay. But what happened? He didn't give the newspaper. He gave the iPad, Apple iPad. So she hit in that iPad only the cockroach. Okay. So what is the moral is, whatever smartness is there or your intelligence is there, show in the office or in the conferences, not in the house. So this is the moral. Okay. So And sometimes whatever they tell, if you go to the sleep or a deep sleep, it is more helpful for both of us, husband and wife. And during the antenatal period, this should not happen. You know that you can't keep going in the bike or traveling whatever speed is there. You know, Bangalore roads are very bad, and wherever you go, it will be digged inside. Okay. So see that these things are avoided, or take a route which is more good, or as much as vehicle traveling should be avoided. And as I told you in my starting of this life, the office also should be as much as near or in the ground floor. If it is there, it is more helpful. So these things, if you take care, it is more good for the antenatal period. So take care for the walk also, which is helpful. And sometimes what happens, where you should keep talking also well. See, sometimes you know, ladies, you know, they usually expect before marriage. I should okay, but after marriage, whenever you go, they suspect. But after the death, 100% they'll respect. I said okay. So in this way, it keeps going on. Okay, and you give the gift whichever best possible within your limits. Not that you give any costly gifts only. Okay, and sometimes what happens, once there was one diamond necklace given to the wife in her 10th anniversary. Okay, and what happened is after giving the diamond necklace for the anniversary, 6 months later, the wife didn't talk to the husband. All his friends, whoever came to his house, they kept on asking, what is this, man? You are given such a good diamond necklace and she is not at all talking to you. No, it's okay, man, you leave it. No problem, I'll just solve this problem. No, they kept on asking, you know, people know this. Friends, some friends will be there during the drinks taking in the night. No, they won't listen itself. They keep asking, digging, what happened? No, then after repeated forcing, no, the husband started telling that when I gave the gift, the deal was that we should not talk to each other for 6 months. I said, okay. So that was happened. Okay. So, but otherwise, whatever she likes during the antenatal period and during the postnatal period, see that you give her the as much as good gifts whichever she likes, and take her to the walking or to the nearby places whichever is comfortable for her to keep her more happy, which is much necessary for her. And see that she gets, you don't alone get ready, see that even she also gets ready. And you should see that you do the household works during the antenatal and postnatal period, which is more comfortable for her, and do not give more stress or pain to the carrying mother or the postnatal mother. So where, see, ultimately you will be seeing that the baby is more smiling, baby is more feeding the breast milk, and it is sleeping comfortably, and mother is also sleeping. That itself makes the father or the husband more happy than anything else. Well, and see that when you go to any functions, or allow her to give her some time to get ready. Do not keep forcing her, get ready fast, all these things again. And this is again regaining the figure. I just told you this previously. And very few things only I have told her, but very important is this message, whatever I told you. See that you go and tell your friends, lady friends, that too. Okay, because nowadays, whatever the speed, WhatsApp might have come, email might have come, or post or speed post courier, anything should have come. I should, okay, it can't spread as fast as you tell the ladies, because they will tell other ladies. Tell that lady not to tell anyone else, so it will spread more faster. Okay, so the message is, see that you keep spreading this information to your friends as much as possible, and which will help the antenatal or postnatal mothers to become more happier, and to give the breast milk more well to the baby. Last few slides, and these are some slides which have been told already from morning. I think we deleted. Yes, ma'am. Yeah, that's what it is. No, it was deleted. I think the other thing have come out actually. Yeah, I think these are all okay. This is the last slide. You can see here the mother and the baby are so happy, so smiling, and the baby also is feeding well, and even taken care well. And the reason, every successful man has a woman behind her. But if you discuss more, every successful mother and the baby, and the smiling and the happy mother and the baby, behind them, the father is always there. You can see there. Okay, so that is the message I want to give in my talk today. So telling this, I think, thank you. To find you know this Anjaneya, he went to Sanjeevani Parvata to get the drug, whichever Lakshman wants, because when he was unconscious. And the drug, happiness drug is, don't go in search anywhere in the world that your happiness is there, their happiness is there. I should get, it is within you. So you are holding your happiness with you. Keep happy yourself, keep the happy. The people surrounding you, that itself is very good for your health also, and even your wealth also. So telling these things, I think I'll conclude my slides. So thank you for listening to my talk. Thank you.
Thank you so much for stimulating and humorous talk. So that goes well with the mood. Many people are already ready for lunch. So we'll break up for lunch. We'll come back, rejoin at 2:45, please. Yes. Well, there is one talk was not there, no, ma'am. Next is the panel discussion. We have panel discussion. But the problem with the panel discussion is everybody is going to join at 3 o'clock. International speakers, and we have speakers from Delhi. So they have been given a time slot, and they will join only exactly at that time. Okay. Yes. Yes. So 2:45 sharp, we'll come back. Okay. Thank you so much, and enjoy your lunch. And leisure is a beautiful resort. You can just have a stroll around, maintain social distancing. Okay. Thank you.
Good afternoon and welcome back to our afternoon session. Hope you all of you all had your lunch. So without further ado, we'll move on to our panel discussion. So moderating this panel discussion is Dr. Srinath S. Manikanti, who is a senior consultant and neonatologist at Kaveri Hospital. And his areas of interest are neonatology, neonatal cardiology, perinatology, and human milk banking. Other panelists on this session are Dr. Suman Rao. She is also a professor of neonatology in St. John's, Bangalore. And we have Dr. Asha Benakappa ma'am with us. She's a HOD of pediatrics and also a former director of Indira Gandhi Child Health Institute. And from our international panelists, we have Miss Anne. She is the milk bank manager at Oslo University Hospital, and she's also a qualified lactation consultant and works with mothers in the NICU. She has breastfeeding. She's also a board member of EMBA, which is European Milk Bank Association, and has in-depth knowledge about milk banks around the world and their functioning. Joining today also is Dr. Mary, who's Global Sales Director and PhD from Uppsala University and has been working in the field of human milk composition, analysis, and individual fortification. Over to you, sir.
Also, we have Dr. Raghuram Malaya joining from New Delhi. He is the director of neonatology at Fortis Law Firm, and he is a co-founder of Breast Milk Foundation and Amara. So thank you all, esteemed panel, for this wonderful session. And I'm really privileged to moderate this session, and it will be really fascinating with a mix of different skills and different expertise across the globe. So in the next 45 minutes, we'll discuss about breastfeeding of preterm infants in the NICU, and also how Human Milk Bank comes to their rescue. So first of all, greetings from Garden City of Bangalore, and especially to our international panel who have not visited this city. And it's a Garden City of India, and Next, when you get an opportunity, please do come and visit us. So we'll start with a case scenario. So 28-week primey with severe preeclampsia. Estimated fetal weight is 830 grams, is being taken for C-section in 4 hours of age. In 4 hours time, we have another 4 hours to go for C-section, okay? So mother has already received 2 doses of antenatal steroids and currently magnesium sulfate is going on. And the neonatal team has been informed to come and counsel the mother. So the first question is to Dr. Suman Rao. Dr. Suman, how do you counsel this mother regarding expression of breast milk?
Yeah, thank you, Dr. Srinath, for this opportunity to be in this wonderful panel. And your question about what to do and how to counsel the mother, I think our job actually has to start even much before this. A lady in labor, this is not the best time for counseling. So in fact, counseling about breastfeeding as a rule, and particularly if the lady is at risk for a preterm baby, should be started right from the time that you identify these issues. Like say, we know that she has PIH, it's resulted in IUGR baby, and this baby, the fetus is going to come out early. I think even then itself, we should start talking about the need for expressing milk. And one of the things that we tell the families is, just as we are going to take care of the immediate problems of this baby who is so small, you also have a big role. And just because the baby is small, the baby should not miss out on the most important vaccination or the most important gift that the mother can give, and that is breast milk within the first hour. So we are trying to now ensure, initially we thought that the preterm baby should get colostrum within first 6 hours, but now our goal is like any other baby, the preterm not only needs, but also is at a greater need to get the colostrum within the first hour. And for this, the healthcare personnel and the family should work together to help express milk. And, you may not get much, but at the same time, I think there should be an effort to get milk out and give it to the baby. So what we are now counseling the families is, we might forget, but you should make the demand that your baby should get milk. So we sort of spread the responsibility, that so that at least some of us can try to ensure that the baby gets milk. Over.
Absolutely, Suman, spot on. Mother is very anxious because baby is taken away from her, and it's going to be away for quite a few weeks. And she feels helpless that, see, majority of the things are being done by the doctors and nurses. What I'm doing, I'm not contributing to my baby. So that's the feeling that the mother will have. So it is very, very important to get the mother going and then counseling the mother as in the earliest opportunity. Unfortunately, in this scenario, the mother came up with an emergency admission and we didn't have much time to counsel. So now, when do you advocate expression of breast milk, and how often and what methods do you recommend the mother? So when do you advocate expression of breast milk? See, we have another 4 hours before we go for C-section. Why I'm asking this question is, I was in one conference where Dr. Neena Modi from London, Imperial College, was giving a talk. And in fact, she says, if there is an elective section for a preterm baby, and she would start advising expression of milk even before even C-section. I know we would not do that for a mother who is not in labor for the risk of precipitating a labor. But here there's a planned section in 4 hours. And could we make this opportunity to express milk? And when do you want to encourage?
So I know we had this discussion earlier, and I was also fascinated by what you said. But frankly, in our unit, we try to express milk after the baby is born. We haven't started helping the mothers express milk before the birth of the baby. And but I think it is something good to look at if that is going to help her, because these preterm mothers need every tool in our kitty to help them get milk out and ensure that their babies get only mother's own milk. We try to express right from the beginning, and currently we have I work in a medical school, and there we are asking all our residents that if you're getting a baby from C-section, you should not get the baby alone. You should get a syringe with the colostrum also, even if it is a few drops. We might not be able to put it and give it as a feed to the baby, but we can definitely at least coat it into the baby's mouth. And therefore, we should consider that colostrum and express milk right from the word go as soon as the baby is born. But your suggestion of doing it antenatally, I think, is quite welcome. Over.
I would like to invite comment from Anne Goslin. Can you please comment on this? We have 4 hours before C-section. And would you do...
Thank you for inviting me to participate. In Europe, it's more and more common to actually collect colostrum before birth, if you know that the baby will be born sick or preterm. And of course, we have another situation with deep freezers at home and more better environment in some places. But we do have mothers coming in with small syringes where they have collected drops of colostrum, bringing it with them to the ward before the baby is delivered. So I think that's the way to go to encourage the mothers to start really early, and also to ensure that the babies get milk from the first hour. Thank you.
That's really fascinating. In fact, I was reading some studies where they say if the mother starts expressing within first 24 hours, they lactate much better than when they start expressing later on. Even within 24 hours, if mothers expresses within 6 hours or within 1 hour, if you compare, the mothers who start expressing within 1 hour after birth, they lactate much earlier and lactate well compared to the mothers who express within 6 hours or 24 hours. So earlier is the better. So even if you have a time before the C-section, yes, why not? Why not use it? Fantastic. Thank you so much. So next slide. So this baby is born, and this baby required intubation and ventilation, and surfactant is given. And the baby is exhibited to CPAP on day 2, and we have umbilical lines in C2. So baby is otherwise hemodynamically stable. Mom managed to collect few drops of colostrum expressed, and which was given as mouth painting. Okay. So the next question to Asha Bedankappa madam. Ma'am, when would you advise starting KMC for this baby? And how would you motivate this mother to continue to express milk?
The KMC should be started immediately. Now we are getting into the concept of IKMC. And then KMC went, we have ventilated babies also on KMC. So I would start immediately as soon as the baby is born, because we believe more in zero separation.
Oh, that's absolutely right. But the baby is in the first few hours, baby is ventilated.
Earlier,
umbilical lines.
Yes. Earlier we were saying that with tubes and lines, we will wait till the baby is stable. But the latest recommendation is even before that. Safdarjung Hospital, which Sumana Rao put it up. And in that particular study, even when all those tubes, everything is going on, you can still stabilize the baby on the mother's chest. And the mother's chest is the best environment for the baby. So that now they're calling it as small I and KMC, immediate KMC. How would you motivate this mother to continue to express breast milk? We are in a very difficult situation because the mother is totally shattered and shocked that a baby is born so prematurely, and then she has to go for a cesarean section, and the weight of the baby is 830 grams, right? Yes. And the gestational age is little 26 weeks.
28 weeks. Yeah.
28 weeks. Then 28 weeks, there should not be any issue. So intense counseling, counseling skills, the best of counseling skills are required here. And we have to counsel her and motivate her. Because I've always been saying breastfeeding is all about confidence trick. You know, the more you motivate her and more oxytocin release, more easy to express the breast milk.
Okay. And how often do you advise her to express milk?
Initially, in the beginning, the first hour is very, very crucial, like the other person told us, and they have started and brought it to the hospital, the colostrum in small little aliquots. As soon as the baby is born, that's the best time to express the milk, because immediately that particular milk, we were talking about lactogens in my previous talk, lactogens 1, 2, and 3, immediately after placental separation, it's very easy to express the milk. I would recommend expression every 2 hours.
Dr. Suman, would you like to come in?
Yeah, I think I thank Madam, and it's indeed a pleasure to be, with my teacher, Dr. Asha Benekappa, on the same platform. Madam, it's indeed my honor. And as you rightly said, I think the concept of zero separation is very much needed for the preterm. And the immediate KMC study has shown that this is the way to go. I know in the Scandinavian countries, they have been practicing this for, more than a decade now. And now this has spread to the world, and it is up to us to take on this and build NICUs which are facilitating this. So we need to get the moms, not only the mother's own milk, but the mother herself into the NICU. So we need both kind of moms in the NICU all the time. Over.
Thank you. And Gazin, what is the practice in Europe in the first few days when the baby is on either ventilator or on CPAP with umbilical lines? How do you go about doing skin to skin?
We try to do it as soon as possible. As I work in the main hospital in Norway, we have the sickest of all the babies from all over Norway. But in the other NICUs, there is KMC as much as possible, as early as possible. And there's a lot of procedures you can do with the baby on your chest. You don't have to separate the baby to take blood samples or other procedures. That can be done while the baby is still on the mother's chest. So we try to keep the mothers and babies together as much as possible. And there's some units where that are built so the mother can actually be there 24/7 with the baby. They have like their own bed, so they can monitor their own baby 24/7.
Thank you, Anne. So next slide, please. Okay, let's move on. And the baby in day 3, the baby is on CPAP at 30% FiO2, and blood gases show permissive hypercapnia. So the umbilical lines are still there. And baby is hemodynamically stable. And the baby is receiving full TPN. And still mother's own milk is very little, only enough to give mouth painting. Next question to Dr. Raghu. Raghu, when would you like to start feeds for this baby? Would you wait for mother's own milk or start on any alternative feeds? If you decide to start feeds, which alternative feeds do you give and why? Raghu, are you there? You can unmute yourself.
Hi, Srinath, and good afternoon, everybody. It's a great pleasure to be a part of this discussion today. Breastfeeding and breast milk bank is something that's been very close to my heart, and we've been working a lot to improve this in different parts of the country. If I can have the question back again, Srinath, when do we start feed? I think that's a no-brainer.
Sure.
We need to start the feed
Can you see
at the
screen,
earliest
Raghu?
possible time. Yeah, I can see the screen. Yes. Yeah. Thanks. So I think when to start the feeds is a no-brainer, and we should start the baby on feed immediately after birth. There's absolutely no reason not to start the baby on feed. And again, the next question is it has to be mother's milk. There's no two ways about it. And there are enough studies and our own practice. And clearly common sense tells us that the most important thing is to give the mother's own milk. Although I have the pleasure of being attached to a milk bank in our hospital, we very seldom avail this service because we encourage most mothers to use their own milk. There's absolutely no doubt that the mother's milk is far superior to the donor milk. And the donor milk is always used only as a stopgap measure when the mother's not getting enough milk. We, as people have been speaking earlier on, we counsel most mothers during the antenatal period, especially if they're having a preterm baby. It is all the more important. In fact, actually, one of the problems we had was a lot of people used to insist about term babies being giving the mother's own milk and the advantage with it. The advantage for a preterm baby is way ahead than what it is for a term baby. So every single mother is usually counseled, and we try and get them to start expressing within an hour after the birth. And most of the mothers do get milk. In fact, it was very interesting because we had done a telephonic survey. At one hand, we are talking about getting mothers to start feeding with their own milk as early as possible. A number of units across the telephonic survey, which we've done about 4 or 5 years ago, were hardly ever using mother's milk. Most people believe that a preterm mother would not produce milk, which is so contrary to what happens across the world. So it is something that even the doctors have to be educated and have to be told that they need to tell the mothers to express milk. And obviously, if you do not have mother's own milk for whatever reason, then obviously the next best thing is the donor human milk. And now there are banks across which can supply milk, and one should use donor human milk. Only if you don't have any of these, then we would look at using formula, but every effort should be made to use breast milk.
And why do you want to use donor milk? Only as alternative?
So, yeah, so like I said, there are a number of studies. Srinath, that slide doesn't focus very well. So let me just,
Just put
can
the
I?
slide again. Make the full screen, please.
It's not actually focused, so I'm not able to read what is written there.
Are you able to see now?
Just a second.
This is a systematic
just-
review and meta-analysis.
Yeah. So if I can just show this to most of the participants about a very good systematic review of preterm babies. This is one of the very few large meta-analysis which was done. This was presented in 2018 by Jacqueline et al. And they looked at babies who were born less than 28 weeks gestation or less than 1,500 grams at birth. It was a very large study. About 17,000 babies were preterm babies were included in this study, starting from 1990 onwards. So spanned over 2 decades. They had about 6 RCTs in this, and the others were mainly systematic observational studies, 43 observational studies. They divided them into 3 groups: exclusive human milk, and they compared those with babies who received only exclusive preterm formula feed. They also compared babies who had any amount of human milk, which means the baby could have received some amount of formula feed in between, but received some amount of human milk in this group. And they compared them also with the exclusively preterm formula feed. And they also did a sub-analysis of mother's own milk versus donor human milk. If you can go to the next slide, Srinath.
Yeah, next slide is on Raghu. Can you see?
Yeah, and they looked at the outcome measures, which were very interesting outcomes. One was obviously NEC, and they divided this into any NEC, which could be stage 1, stage 2, or very severe NEC, which was stage 3, stage 4 NEC, which would probably require intervention. They looked at late onset sepsis. They looked at bronchopulmonary dysplasia, retinopathy of prematurity, which is very interesting, and what its relationship is with breastfeeding. And they also looked at neurodevelopmental outcomes up to 2 years of age, including cognitive and motor development. If you move to the next slide, Srinath.
Yes, it's
The
already on.
study was very interesting. The results were very interesting. They showed that babies who had exclusive human milk, and any human milk for that matter, even if they received a little bit of breast milk as well, as opposed to being exclusively on preterm formula feed, it reduced the incidence of NEC. And this, obviously, we have known from a lot of studies that breast milk is protective. But what was interesting is that even if it was a little bit of breast milk, it still helped in decreasing the incidence of NEC. When they went on to compare the subgroups, which is exclusive human milk than any human milk at all, which means the babies who had some amount of formula feed and some amount of breast milk, in the exclusively human milk fed babies, there was a very significant decrease in NE as well as severe NEC. So it made a large difference for severe NEC. What was also interesting was in the exclusively human milk fed group, there was a 5% decrease in late onset sepsis and also a 7% decrease in ROP. There's been a lot of studies now coming out in support of breastfeeding and ROP. There was a very large meta-analysis which was presented in the US very recently, where they looked at exclusively human milk fed babies and a substantial decrease in ROP, which is a very interesting thing. And this is attributed to the ARA and the DHA in the breast milk. So that's an interesting finding. They did not get any difference. Sorry, next slide, Srinath. Yeah.
It's already on, Raghu.
Okay, yeah. There was inconclusive evidence regarding outcomes such as BPD and neurodevelopment. They did not find any difference in these groups. And there was no difference in NEC between mother's own milk and the donor human milk, although the numbers in these studies were very small to come to any sort of substantial conclusion with this. So what has this got for us? What implications does this have in practice when we're looking after preterm infants? I think the first and foremost thing is, which has to be reinforced at every point in time, is every effort should be made to exclusively give mother's own milk, because we definitely know it will decrease NEC, not only NEC, but also sepsis and ROP as well. If for some reason the mother's milk is not sufficient and the baby is on preterm formula, however little mother's milk is available, you should still make this effort to give even a little bit of breast milk. If you're not able to exclusively breastfeed this baby, at least some amount of milk should be given, because the definite decrease in NE and severe NEC. So the other way, converse of looking at it is exclusive preterm formula is bad for the baby and puts the baby at high risk for NEC, sepsis, and ROP. So next slide, Srinath. Donor human milk should always be used in preference to formula feed whenever access to a bank is possible. As I was mentioning earlier, the number of banks across India have been increasing, so it is possible to get, but people and doctors should make the effort to get the donor human milk for these babies. If baby is only on preterm formula, it is justified to top up with donor human milk. Even in those babies, even if you can't keep them entirely on breast milk, you should try and give at least some amount of donor human milk. So I think that sort of answers the question of why human milk, whether it's mother's own milk or donor human milk, is important for these babies.
Thank you, Raghu, for the excellent argument. And also there's no argument actually. So everybody knows mother's own milk is the best for their babies because it is dynamic and it is catered to specific gestation. And the first alternative, the only next best alternative is donor human milk, and every effort should be made to get mother's own milk as early as possible. In the event of not getting the mother's milk, you have to go for donor milk. That's where the breast banks come into effect. So coming to this baby again. So now the baby is day 8. So baby is much more stable, still on CPAP, just tolerating about 1 hour of CPAP. Hemodynamically stable. So umbilical lines are out. And PIC line is in C2. And baby is on their feeds, of which 50% are Pasha's donor human milk and 50% mother's own milk. And for some reason, KMC still did not happen. Although we insisted on KMC, but nurses were a bit skeptical. Maybe doctors were not insisting enough. Somehow it didn't happen. So what can we do about it? So how do you make sure KMC actually happens? Dr. Asha, madam?
It needs immense counseling, and we need to have a lot of support system. And 8 days is quite a lot of delay. Now that all the lines are out, let's put in all our efforts and put the baby on the mother's chest. And that's the best eco environment for the baby.
Absolutely right. Dr. Suman, you want to come in?
Yeah, like ma'am said, 8 days is quite a lot of time. And now with the knowledge of immediate KMC, it seems so long. This has to be a concentrated effort by everyone who comes in contact with the family. Not only the nurses, the doctors, but also people like our security guard who is sitting there. She should be welcoming the family to come. Did you do KMC? I mean, that's kind of a greeting. So I think the culture of KMC has to happen if KMC needs to take off. And the very important thing is counseling. But what we have found is that the barriers to KMC are not the families. The families are ever ready to embrace kangaroo mother care. It is the health workers' conviction, which I think is most important. And that is where we need to invest and convince them that even the smallest babies are safe on the mother's chest, and also ensure that the baby is safe by continued monitoring. When we say that these small babies need KMC, it doesn't mean that they are stable. They still could have apnea, they still could have problems, and therefore we need to ensure that the monitoring continues, everybody is ready for it. And once the nurses and the health personnel see the benefits, and mind you, the benefits may not be immediate. The benefits is lifelong. So some of them may not even see, but some of the tangible benefits they can see is in lactation. Even half an hour of KMC will improve the mother's lactation. So these are the things that we need to convince the health workers, and all of us speak the same language, counsel the families. Starting KMC, I have not found a barrier. My main barrier we have found is in increasing the duration of KMC. We used to get stuck till around 8-9 hours, and we ourselves used to feel good that we are achieving 8 hours. But when I saw the results of the immediate KMC study, and I actually saw the mothers when I did the monitoring visits do 20 hours of KMC per day, then we realized that we need to give that kind of environment to the family. You can't tell them, come sit next to the baby and do 20 hours of KMC. We have to have an adult bed in the NICU, and we need a KMC ward in every hospital which takes care of preterm babies. That is, the government has done that very good thing that every district SNCU is a mandate to have a KMC ward. Similarly, I think in every private hospital, anyone who has an NICU, a KMC ward should be a mandatory support for the family. So if we create an environment, I think it is possible. So a culture and a culture of KMC by all the health workers, and good counseling, counseling by everyone in the same culture, in the same tone. And lastly, creating a system where the mothers can do long hours of KMC is what is needed. And please remember that we need family support. Long hours of KMC definitely needs the families. It's not just about the mother. Over.
Thank you. Thank you, Suman. Thank you. Wonderful. That's wonderful. And we always say donor milk and human milk banks are the only there to fill the void. There's only a stopgap arrangement until the mother milk kicks in. We are not here to provide donor milk forever. Nobody advocates that. I'm sure Dr. Raghu will completely agree with me. So in this mother, we are still on 50% of donor milk, 50% of mother's own milk, despite mother is expressing. Would you recommend galactogogues to this mother? And how do you encourage the mother to get more milk? Because we need to move to full feeds on mother's own milk shortly, right? Dr. Ma'am, Asha ma'am.
The best galactogogues are counseling. I do not believe in any galactogogues that are available in the market. They may have, placebo, but counseling, like even Suman has been emphasizing on that. I run a helpline, and it's called a lactation helpline. I've worked with all kinds of mothers, and the only thing is counseling and the support system. That should be stressed all the time. Absolutely no role. And if the mothers feel, if they're eating some herbs, and if they're feeling that they're getting milk, as long as that practice is not harming in any way, let's leave it alone. But as such, let us not bring another interface. I've been talking about interfaces between the breast and the baby, the galactogogues. That's my opinion.
Okay, thank you, Dr. Asha. Dr. Suman, do you prescribe
Srinath,
any
if I can-
galacticals to this mother? Oh yeah, yes, Raghu, you want to come in? Yes. Okay, Raghu, go on.
Yeah, I think that's a very important point. I think people place too much importance on the galactogogues and other sort of surrogate measures to increase the breast milk. I think the most important thing is to counsel the mother and motivate the mother. In our unit, in fact, actually 30% of the milk we receive to the milk bank is from mothers who had their own preterm babies. And this is an absolute statistic, which is not, I'm not making this up. This is our statistics which we get because we tell the mothers they are the most motivated people. We as health professionals should just encourage them. And most of these mothers start pumping milk out. Almost 30% of our milk, which we get donation to our milk bank, is through the mothers who have their own preterm babies. Like I said, there's a huge cultural issue about even in healthcare professionals who feel that mothers who had preterm babies will not lactate. And it's been taking us such a long time to try and convince people that this is not true and you should tell mothers to start pumping the milk out. Once the mother starts pumping her milk out, irrespective of what she eats or drinks, she will produce enough milk. We have very, very few mothers who actually don't produce enough milk that on the days usually get enough milk. And as you know, they need very little amount of milk in the very beginning. Most of these babies are like 800, 900 grams, 1,000 grams. So I think people place too much importance on galactogogues. We just need to encourage mothers to breastfeed and do the start expressing the milk immediately after birth. And they need to express every 2 to 3 hours. And most of the time they do get enough breast milk.
Absolutely true.
Can I just add, it's a process, you know, it's a process. It just won't happen overnight. I mean, it's few hours. Every hour the mother makes improvement. Counseling, support, and privacy. And constantly they should be talking to you. I get mothers, as soon as they go home, they'll come send me a message saying, I don't think my milk is enough. My family is telling me that I should go for formula. In one day, I'll get at least 25 questions, though I've spent 2 hours with the mother. So it's a continuous process. You really need dedicated people in it.
Absolutely agree. So we had actually 26-week twins, although we had in-house human milk bank. These both the twins did not require a single drop of donor milk, and in fact, mother was producing so much she even donated to milk bank. So as it is important to motivate the mother. That's right. We'll move on to the next question. Slide, please. We have Mary Ekong from Sweden, and sorry, we have not forgotten you. Your turn will come. Please be there. Please be patient, Mary. So, okay, that is done. So, okay, next question is to Anne Graslin. So, what is the global scenario in the milk banking and the effect of pandemic on human milk banks across the world?
Oh, that's a big question. In the beginning, we saw a lot of problems in some countries where babies were separated from the mothers in the NICUs. People didn't know if human milk from a human milk bank could be used. But very, very soon we found out that the antibodies from COVID positive donors will be found in the milk. And I haven't heard of milk banks that have been closed, but there was a change in the collection of milk. Most milk was, as you probably know, in most milk banks in Europe, the milk comes from donors with healthy babies from outside the hospital. We do have mothers from inside as well, but most of the milk comes from outside. And what was implemented was that the milk was quarantined for 2 weeks, 10 days. And then we had to call all the donors to ask if there had been any COVID in the family or with the donor before we could clear the milk and let it go through the system of testing. So there was a lot of frustration in the early months of the pandemic, but after that, things has been quite normal. we also saw a drop in preterm babies in the beginning, which led to a lot of extra milk in the milk banks. And especially here in Norway, we saw that a lot more donors were coming forward because there was like this wave of people wanting to help. We had a totally closed down country for many, many weeks. And people came forward and they wanted to help. So I had so many emails and phones from mothers that wanted to donate milk. And that has continued. So my milk bank has never been fuller than it is right now.
Put up the slide, please. Raghu, how did it affect your milk bank in New Delhi?
Srinath, we did not have much of the problems. Obviously, in the very sort of first month, everybody's a bit confused. So sort of April and May as to whom you should collect it from and whom you should not collect. But we did not have much drop in the breast milk donation. Our milk also mostly comes from outside the hospital, like what Anne was saying. Most of our mothers are long-term donors. We used to get we used to ring them on a weekly basis to make sure that nobody had the infection. Obviously, if they had the infection, we were not collecting milk from those mothers. But otherwise, it did not affect our breastfeeding rates. In fact, we had a lot of demand of breast milk for the first 6 months or so. We started seeing a drop in our premature babies around about the 6-month period because the IVF process had stopped. But the first 6 months, we had a lot of demand and we continued supplying milk to most of the banks. As you know, we are a public milk bank, so we supply to other hospitals. So we did not see much change, and the bank has been working more or less like what it did normally. And now we have more understanding about mothers who had COVID and who are donating milk. Their antibodies are going to their own babies. So we did not see much of a difference.
So what I noticed is breastfeedings definitely did affect in majority of the hospitals, because when in March and April, when the COVID was still new, I heard a lot of hospitals actually separated the babies from the mother when mother had COVID. And up to 2 weeks, it was really shocking. The baby was completely separated. Some mothers came to me after 2 weeks, after they got discharged, saying that I have not put the baby on the breast. My breasts have dried up because the baby was separated from me. So it was really challenging, but after that, we could actually put the baby back on the breast, and fortunately, this baby went on to breastfeed. Unfortunately, in the beginning of the pandemic, yes, the babies were separated. In our hospital, we had so far 51 deliveries of COVID-19 mothers, and we made a special ward, and we made sure that all these babies were breastfed within 1 hour after delivery. Mother wears N95 mask, hand hygiene, breast hygiene. We have a separate nurse with PPE who helps these babies go onto the breast within the 1 hour after delivery. Thank you. Yeah, a pandemic is quite a challenge, and we are all dealing with it. And as they say, with every adversity brings it equivalent or greater benefits. So we have learned so many things, and then probably we can actually move forward. Next slide, please. And there is one more question for you. And what is the importance of human milk? Yeah. So what's the importance of human milk banks, especially in the Indian scenario? Would you like to comment?
Can you please repeat the question?
So what's the importance of human milk banks, especially in the Indian scenario?
I think it's very difficult for me to be an expert on India, although I used to call myself half Indian since I've spent so much time there. But I've seen quite a lot of India and many hospitals and many milk banks. I think the most important thing for India is to upscale the lactation counseling and the support for mothers and the environment for mothers. With better support, there will be less need for donor milk, and that will solve a lot of problems. I don't think the answer to all the questions are more milk banks. I think the answer is more knowledge and more support for the mothers. And also, I think like bigger, better milk banks with qualified staff rather than small milk banks with lack of knowledge, which I've seen some places in the world, is not good. So I like to have bigger milk banks with more staff, qualified staff, that can ensure that the quality is good for the end product. And
thank you, and I completely agree with you. I would like to just share our experience. Dr. Raghu, who is there in the panel, as well as we both started Amara Milk Bank, the second branch. He takes care of Delhi branch, and then when the milk bank was started in Bangalore, and I was taking care of it. And when Raghu introduced the milk bank, it was a completely new new idea to Karnataka. It was a completely new concept. Until then, there was not a single human milk bank. The whole culture has to be changed. All these babies were on preterm formula. But now I can tell you, in 4 years, we were able to do a complete culture change. We are supplying donor milk to 53 NICUs, not 1, 2, 3. So initially, we really struggled for the first 6 months, but with so much of effort, reaching out to all our colleagues, networking and doing media bites, and then articles, and giving talks, conducting CMEs for neonatologists, lactation consultants, obstetricians, and creating awareness. We were able to bring the culture change. And now 53 NICUs use the donor milk, which is given by Amara. So that's a huge culture change. So yes, not just opening many milk banks is not an answer, but functioning milk bank with very dedicated staff, and which can actually cater to many hospitals. Yeah, probably is. Raghu, would you like to come in?
Yes, Srinath, I think like all of you have been putting it across, you need to have a hub and spoke mechanism. Running milk banks is not an easy job. There's a lot of work. There's a lot of funds that are required to run the milk bank. If you want to run it in the with the highest or the strictest stringent measures, we have to have an effective method of collection of milk and distribution of milk, and we need to invest more time and money into collecting and distributing milk in a proper and a safe manner. We've been extending the distance till what we can distribute milk. We've been distributing milk up to sort of 200 kilometers away from our own hospital now in a very safe and effective manner. And we encourage people to, there's a lot of mothers who want to donate milk, but they're not aware. There's no sensitization. In fact, a lot of the clinicians don't know that they can donate milk. A simple scenario is if your baby's got NEC and you kept the baby nil by mouth in your unit, it is very important for the mother to continue expressing the milk and not stop expressing the milk just because she's not feeding the baby. Because once you restart feeding for this baby, it is important to feed the baby with her own mother's milk. It's a very common scenario, and you end up, and nobody tells the mother she needs to express the milk. And when they need to restart the baby back on feed, there is no milk for the mother. And a lot of times these mothers who express the milk, they can just donate it to the milk bank. And I've been speaking to a lot of doctors and my colleagues over here to come forward. And whenever they do tend to have this scenario, to keep making sure that they donate milk to the bank. So I think to put it back into 2 words, I think effective collection and distribution rather than starting many milk banks, because it is a lot of funding that is required to keep these banks going. And we need to sustain these banks in the long term.
Slide, please. Okay, we'll quickly move on. So this is a question to 18 Colgate. I think he has not joined. So Raghu can actually, you can take this question. So what is a safe pasteurization and why it is necessary? And also you can take this question also. What are the global standards of safe pasteurization?
Sorry, Srinath, I missed you. Is it for me or for somebody else?
Raghu, you can take. Actually, 18 Colgate did not join. Okay, he was supposed to join. He didn't join, so you can take this question. So what is safe pasteurization and why it is necessary? And what are the global standards of safe pasteurization?
So pasteurization is basically, as we all know, it's done to make sure that the donor milk is safe because you're collecting milk from multiple mothers and you're mixing the milk and then distributing it. And the last thing you want to do is to give these babies infection. And that's why it's important to pasteurize the milk. Most people across the world use the Holder's method of pasteurization, which is they heat the milk up very quickly to about 62.5 degrees centigrade and holds it there for half an hour. And then they rapidly cool. And then this milk is then frozen and then distributed to the different recipients. And the recipients would most probably be premature babies who are the most vulnerable people of our population. And that is what the whole idea about pasteurization is. To be doubly sure that you've done a good job with the pasteurization, obviously kills most of the bacteria as well as the viruses. People have been looking at different methods of pasteurization, which is the ultra heat therapy, which is a very quick pasteurization. I think there's a lot of research happening in Holland and for that matter in the Scandinavian countries as well about the ultra heat treatment, which is known as the UHT, which they do for cow's milk as well. We do not have any commercial units as such. Most of these are under studies, and Anne can come in over there. But that's another method of pasteurization. So it's mainly to destroy the bugs so that you give them a safe milk without destroying the important nutrition qualities of the breast milk. So generally with the Holder's method of pasteurization, you don't change the macronutrient composition of the milk. So the calorie content is usually preserved, but there is some amount of loss of lactoferrin, lactoglobulins, and immunoglobulins in the milk. Although there's a lot of work which is going on, the important things like DHA and human milk oligosaccharides doesn't seem to be affected by pasteurization. So it's a fairly safe method, and there's a lot of argument happening about how good or effective pasteurized milk is. And most of the studies have shown that pasteurized milk is still good, but yes, it may lack a little bit of the antibodies and the immunoglobulins and the lactoferrin and the lactoglobulins.
Thank you, Raghu. That is a very comprehensive answer. Anne, would you like to come in with regards to pasteurization?
Yes. Yeah, I want to emphasize what the previous speaker said, that the cooling period is very important. The whole process is heating, holding, and cooling. So I've seen pasteurization going on in water shaker pots, and the milk was put aside to cool on the bench, which is not proper cooling. So people need to be aware of what pasteurization means. It means heating, holding, and cooling. And I got a question in this chat about we use raw donor milk in Norway, and also some units in Germany use raw donor milk. That is a very complicated and expensive procedure to do that. So it's not possible to do that everywhere. You need a long-term donor, and you need to test all the milk, and you also need to retest the donor for every donation. You retest the donor for hepatitis, HIV, and other viruses. So, but that's going on some places in the world. And also in France and Italy, there are now studies and prototypes of other pasteurization equipments. So during the next 1 to 2 years, there will be other methods as well.
Thank you, Anne. That's great. So can you please put on the slide? And finally, the wait is over. Mary, it is your turn right now. Can you please unmute yourself? Yeah, put on the full screen. Yes. Okay, that's done. So Mary, the first question for you is, what is human milk analysis and the technology behind it?
Yeah, thank you for having me. I'm honored to be a part of this panel. So human milk analysis, well, it is actually analyzing the macronutrient content of the milk. And this is done to be able to target the fortification. So the idea is that you analyze a small sample of the milk, and this gives you the macronutrient content of the milk so that you can actually fortify to reach the target that is set for each preterm baby. I mean, there is a vast difference between different milk samples, both between mothers and also within the same mother over time. And the difference can be up to 50% or above or below the number that you're actually thinking, or the concentration that you're actually thinking that you're feeding the baby. And this is a strategy that's called targeted fortification. It has been standard of care in Sweden since the 90s, so we have done this for quite some time. As far as we know, there's no other country that has it as standard of care, but a lot of hospitals around the world is adapting this method. I mean, this is, for me, it just kind of makes sense because we're measuring everything else that we're giving these babies really carefully, everything about besides the milk. We would never give a formula, for instance, if the manufacturer could not tell us exactly what's in this formula. But for mother's milk, we accept this change. And also, if you were to order a TPN for the pharmacy or give the baby a TPN, and the concentration in that TPN would be 50% off what's actually written on the label, this would, of course, lead to a big problem. I mean, the reason that we think this is important is that, of course, what we're giving the baby will affect the growth of the baby. But if the baby is tall or not is not really what we're targeting. What we're targeting is, I mean, nutrition affects so many things. BPD, incidence of BPD, incidence of severe ROP. We have the cognitive function of these babies later in life, making sure that their brains are growing in a proper way. And these are things that if we miss out on the first weeks of life, we can't really regrow it. You can't grow the development of the brain at the later stage, or any of the organs for that matter. So this is what we work for, kind of spreading the word to actually analyze the milk. And of course, this is both for the NICU, analyzing mother's own milk in the NICU is of course important, but also very much important to analyze the donated milk available or delivered from the milk banks. Because a large portion of the feeds for these babies, at least in these first weeks, will be from donor milk, hopefully.
Thank you, Mary. Do you separately pool preterm milk? And when you do analysis, in general, what is the difference that you find between the preterm milk and the term mother's milk?
So, I mean, you need to do a good analysis of mother's own milk. You would need a 24-hour pooled sample of milk because especially the fat content varies depending on which time of day you're actually taking the sample from. So you do need to pool the milk. If this is already done in the NICU, so if you're already pooling all milk that the mother has pumped for a 24-hour period before giving it to the baby, that's not a problem because you can just pool it and then take the sample out of that pool. But if you're not doing that, you would need to either take out an aliquot out of each pumping for the day, so 0.5 milliliter or even less than that, and then pool that for your sampling. And then, what was the second question? Sorry.
Yeah, what is the major difference you found between the preterm and the
Yeah, so I mean that's a tougher question to actually answer. I mean, if you're looking at averages, for sure the protein content is higher in preterm milk than in term milk, but that is not true for all mothers. So you can't say for sure that since you're feeding preterm milk, you're giving the baby a higher amount of proteins. Because there will still be mothers that are really low in protein that has had preterm babies. So for averages, the average is higher in protein, especially. But for each individual mother, you can't really tell. For fat and carbohydrates are quite stable throughout. So we don't really see a large difference between mothers or within the same mother for carbohydrates. Fat for sure is greatly variable between different mothers and for the same mother over time.
Another common question is being asked is, how long do you accept the breast milk from the donor until the baby is the mother's baby is 3 months old, 6 months old, 12 months old? Until then, when can you accept, and what is the minimum protein content that you are actually expecting to be taken as a donor milk?
Well, this is a tough question because this will vary vastly between different countries. So in Sweden, for instance, the mother isn't allowed to have given birth for more than 3 months ago to be able to donate to the milk bank. I mean, for most countries, this will be at least 6 months. If you're going to US, they accept up to 2 years after, or at least 1 year after birth. And it all depends. I mean, if you are actually analyzing the milk, this isn't really a problem because you will make sure to actually have enough protein in the milk that you're delivering out. So I know for most that are doing human milk analysis is a quality kind of step in the milk bank. So making sure that you don't deliver anything below a certain degree. 1 gram of protein is usually what we see as the cutoff level, 0.9 up to 1 grams per 100 mL of protein. For fat and carbohydrates, I haven't really seen any clear guidelines for what it needs to be. But they're also, so if you go to US, for instance, they don't mind so much about the proteins. They are more focused on calories, and then it will be more of a 20 calories per ounce cutoff. So anything below that won't be delivered to the NICU. But then in US also, they have a lot of the milk going out to not hospitalized babies, but term-born healthy babies. So the outpatient category. And for those babies, they don't really have any cutoff levels, which is, I guess, another debate to have, but yeah.
Okay, so not all the human milk banks will have analyzer. And we know that protein contents will go down as the baby ages, right? So in the unit, okay, if you have a milk analyzer, you analyze up to even 12 months, you can analyze and see if the protein content is more than 1, you will accept. That's what you say, right?
Yeah.
But where there is no milk analyzer, how many months do you advise them to donate? Up to 3 months, 6 months, 12 months?
Yeah, that's the question. I mean, it's impossible to answer because you can have mothers given birth 3 months ago that has 0.5 grams of protein in their milk. So it's difficult to give that number. And I would say, I mean, between 6 months and 1 year, there's not really, I don't know why it's at 6 months, because in 1 year, you would still see probably an average of about 1 gram of protein in the milk. So as soon as the milk turns to term milk, that's when you see kind of it stabilizing more around 1 gram. So there's no way to know. There's just no way to know. What's been shown is that if you pull, the more mothers that you pull together, the more likely you are to actually reach the level of 1 gram per 100 mL in protein.
Mix of both preterm and term mothers, right?
No, for all mothers. So even if you are only accepting donations from term mothers, the more mothers' milk you pull together, the more. But that's why if the average is 1 gram and the more mothers you add, of course, you would get closer to that average. But in Sweden, for instance, we don't pool different mother's milk together. So it depends on your routines. And I don't think it's for us to say. I think that's for the clinicians to decide.
No, is there any particular reason why you don't pool different mothers?
Well, I mean, this is more of a tracking reason. So to be able to tell if you find out somewhere along the line that there was something wrong with a donor or a sample from a donor, you can directly tell exactly which babies have received from this mother. So it's easier to find out if something is wrong. So this is more of a kind of a tracking issue. From when you're pooling a lot of milk together, and maybe one donor can be in several different batches of milk, for instance, and have gone out to more babies. So that's reasoning. And I think some hospitals in Sweden also have started to pool, or some milk banks have started to pool between mothers here too. But it has not been the general way to do it.
That's very interesting, Mary, because when I gave a talk in World Pediatric Congress in Berlin, there were many mothers who came from Middle East and some Muslim populated
yeah,
countries.
for sure. Yeah, that's a difference. Yeah.
Is it possible to have one single donor mother? Because according to their religion, if that mother gives the milk for more than 42 days, then it will become like
it's a sibling. Mother. Yeah, it's a sibling. So yeah, kinship. So if you, according to Muslim beliefs, if you have been given more than 2 full feeds from a mother, you are a relative of that mother. So that means that the kids can't get married later in life. And this is, of course, a problem. But I know a lot of Muslim countries have, for instance, Singapore has the Muslim community or their leadership have written a fatwa that actually allows donor milk for preterm babies. So there are ways to go around this issue. But for sure, if you can do single donor pool, for instance, you would be able to track exactly what mother your baby received milk from, so that you can make sure this is not a problem later in life for these babies.
Yeah, we have just another 5 minutes to go. Quick comment from Anne.
Yes, regarding pooling milk, we only have milk from one donor in one pool, and that's due to the regulation we have for tracking and tracing. And yeah, anything else you wanted me to comment on? Well, we don't do.
How long they can donate? How long they can donate the milk? 1 to 3, 6
we
months?
have 6 to 8 months, but I do have donors that have donated for a year. If we have lack of donor milk,
you have analyzer, right? You have milk.
Yeah,
analyzer.
we have an analyzer, but we don't analyze on a daily basis. We analyze some milk for some babies if there's an issue with the growth of that baby. So we use it more for monitoring the babies rather than monitoring the milk in the milk bank.
Raghu, you want to come in? They're very interesting what Mary and Anne say, that they have a single mother, donor mother actually donating for one particular baby. And it's quite a challenge, especially in India, especially with the we need huge volumes to do that. And also a lot of cost is involved. And what is your take on that?
So Srinath, that's something that I've not had to deal with. We've never had any of our mothers, the recipient mothers, questioners about where the milk came from and whom it came from, and was it from a single mother. As a rule, we more or less follow the same as what they do, because we do get long-term donors. So if there's a mother who's donating, then we try and keep her milk separately and pasteurize her milk separately rather than pooling it into a common pool. But there are occasions when we pool milk as well. So it's very difficult for us to determine every single time when a milk is being dispatched to a particular recipient, whether it's come from a single pool or from a multiple pool batch. And we've never had anybody who's asked us or questioned us about it. So we've just kept it simple and we just give the milk to whichever baby needs it.
Thank you, Raghu. So we'll quickly move on. Only the one slide is there. Always questions being asked how long we can actually store the milk. So I'm sure a quick one from Anne. How long we can store the milk?
Well, there is no consensus on this across the world, and in some places you read 2 days, 3 days, but you need to look at which babies are you catering to. If you're catering to the sickest and smallest, in Norway and most countries in Europe, we recommend only 24 hours after the milk has been defrosted. And I think it's quite normal to say, or to keep to 6 months after pumping in the deep freezer. But again, if you have a healthy baby, 18 months old, and you have some milk in the deep freezer, you can give it, even if it's been there for a year. It doesn't turn into anything bad, but the nutrition value might be lower. And
Raghu, would you like to come in?
Yeah, so we do the same. Once it's defrosted, we sort of use it within the first 24, max to max 48 hours, but mostly within 24 hours. And in fact, for the long-term storage of the milk, as most of us are aware, that milk goes faster than it comes in. So we hardly store the milk for more than a month or 2 months. There's so much demand for donor human milk that it just, we need more milk to come in actually. So I think we have hardly kept milk for more than a couple of months in the deep freezer, but our guideline is the same, that we keep it for about 6 months. At the most, but fortunately we've never had to keep it for so long.
Thank you, Raghu. So I just took a CDC guidelines. What it says is, if it is a freshly expressed breast milk, it can be kept in the room temperature up to 4 hours, and in the refrigerator up to 4 days, and in the deep freezer from 6 to 12 months. However, if it is a thawed, previously frozen milk, and it should be used within 1 to 2 hours after thawing, and it can be kept in the refrigerator up to 1 day, and in the deep freezer for about six months. Okay, I think there is a consensus on that. So before we wind out, I would like a quick comment from all the wonderful panelists. We had a fantastic discussion on different interesting topics. I would like to invite Asha Madam to give your final comments.
I'm more into investing on skill training, counseling, and if you do the skill, if you teach the mother the skill of breastfeeding and the expression of breast milk, maybe we should have less dependency on the human milk banks. I'm a little worried about the future of this milk banks and their sustenance. Thank you for giving me the opportunity.
Thank you, ma'am. Dr. Suman, would you like to come in?
Yeah, my key message is, if you keep the mother and the baby together, then and mother's own milk will flow. And yes, milk banks are needed, and it is important to, that's the second best option is donor human milk, but our focus should be on mother's own milk and the mom for the baby, that the mother, her own presence for the baby. Thank you.
Thank you, Dr. Suman. Raghu?
I think most people have covered what I would like to say. Just to add on one more sentence, it's very important for health professionals to make a serious effort to try and exclusively breastfeed the preterm babies. I think that is the need of the hour. Like people spoke about KMC, it is very, very important for most of the preterm babies to be on breast milk. The advantages for these babies are huge, much more important in my opinion than term babies. That is something that is lacking. And a lot of people feel that everything is important in preterm baby other than nutrition and breast milk. They're more interested in putting lines into babies and ventilating babies. And usually nutrition and breastfeeding these babies takes a backseat. I think there should be a change in attitude towards this.
Thank you, Raghu. That's wonderful. So Anne, would you like to come in? Last comments?
Yeah, I think my key message will be that more support for mothers and families, and that will decrease the need for the use of donor milk.
Thank you. Mary, last comments?
Yeah, for sure. And I think I agree. I mean, of course, mother's milk is the most important thing to give to these babies. But I think one thing to remember with the donor milk is that studies actually show that if babies are put on donor milk, it's more likely that they go home breastfed from mother's own milk. So this is also an important bridge and a signal to the mothers how important breast milk is. And I mean, because the ultimate goal is that these babies should be breastfed when they go home. Thank you.
Mary, one last question to you. There's a lot of talk about the DHA and ARA content in different mothers and oligosaccharides. Is it possible to use the human milk analyzer to get DHA area content or oligosaccharides?
No, not at the moment, not with the technique we're using. And I usually say, yes, that would be neat. But as long as we're not analyzing even the total amount of carbohydrates or fat in the milk, going into detail won't really give us that much more for these babies. We need to first focus on actually giving them the correct amount of nutrition.
So thank you all eminent panelists. We are coming to the conclusion of a wonderful session on breastfeeding premature babies and human milk banking. And what we understood is we can start expressing milk if it is a premature baby is already planned for section. You can start even before the section and as soon as possible within the first hour, and keep encouraging her to pump as often as possible and get the first milk and colostrum painting. And not only don't stop over there, encourage KMC early on and continue to support the mother to establish her own milk. In the event, the mother's milk is not coming forth in the first couple of days, do not wait for long, start feeds early. Do not put the baby on TPN for a longer period. Start feeds early, get the baby to full feeds, and meanwhile, mother's milk will come and get the baby to full feeds very early on and continue KMC. And you can fortify the mother's milk if necessary. Then donor human milk banks are there as a stopgap arrangement to help these babies to get human milk instead of getting the formula milks and preventing complications. Thank you so much. Once again, it is really wonderful moderating this session.
Thank you very much. Thank you.
Thank you.
Hello. Any of the people online, if they want to ask questions, please unmute yourself and ask question. Please. Okay. Actually, I'll read out the questions. I think. Okay. Okay. That's the doctor. So testing is essential. Post-pasteurization testing is. So one question from Dr. Muhammad is pre-pasteurization testing essential? Post-pasteurization testing is enough as it may lead to increased discarding of the milk? Absolutely right. See, some people argue that pre-pasteurization, if you do test and if it is heavily colonized, and it may contain some endotoxins, And in that way, we will get to know. However, the studies have proven that these endotoxins are not going to be actually harmful. So majority of them do get denatured after pasteurization. So majority of the recommendation is that pasteurization after, taking the cultures after pasteurization is enough. And also it can, it can prevent the discarding of the milk, and also it is cost effective. I think Anne has already answered Dr. Suman's question about, so raw donor milk, yes. So they were asking, without pasteurization, you can use a raw donor milk. Just do the testing of the milk and continue to feed without pasteurization, without losing any micronutrients. But that has to be only single donor, and that's what she said. It is it's very expensive. Yeah, tedious. So anybody wants to ask any questions, you can unmute yourself and ask. Any other questions? Yes. Yeah. Hmm. Mm-hmm. 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 Mm. 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 Okay, then you have to do pasteurization for every mother's milk. Then first of all, when we get the donor milk, it is come as a frozen, right? It is in the freezer. You freeze all of them. Then you actually thaw it overnight before actually you pull it next day, right? To do a pre-pasteurization culture for each and every mother's milk, then you have to thaw it separately, and then they have to do the culture. That is going to be much more expensive. And anyway, we are doing a culture post-pasteurization. Post-pasteurization culture we are doing. If that is negative, it is absolutely safe to consume. Yeah, one argument is about endotoxins, but the studies have proven that it is not of really much importance, and it's not going to affect the baby in any way. So that's why NICE guidelines and Human Milk Bank Association of North America guidelines don't actually recommend. They say, yeah, if you have enough resources, you can do that. But if you don't have enough resources, don't worry about it. Okay, so you can just do the post-pasteurization culture. One more message. What is that? Can you please come down on the distinct questions? Right side ಹೋಗಿ ಅಲ್ಲಿ ರೈಟ್ ಸೈಡ್ ಕ್ವಶನ್ಸ್ ಇದೆಯಲ್ಲ ಅದನ್ನ ಎಳೀರಿ ಕೆಳಗೆ ಬಾರ್ ಎಳೀರಿ. Okay, Anne Grazin has shared her email ID. So if anyone has any questions, they can email. And thank you. It's really wonderful. So we can all take one picture together. Yes, please come and we'll all take a picture together.
Let him do the ask him what is then you can take
It's under construction. So the engineer has come to us and we are holding. I was there. But they said they have to pipeline behind the water. So I said I will do it for it.
Well, I'm aware and make sure that Thank you so much.
Thank you so much, sir. Thank you for bearing with all the technical issues.
No, it's okay, it's okay. So how was the session overall?
It was really good.
Give the feedback to Jennifer. Dr. Jennifer, okay? What did you think? Really well, right? I think that was more than 1 hour discussion, right?
Yeah, I was asking us feeling how you are going to manage KMC and all.
Yeah.
But then it went well.
Yeah.
So now president should dinner at 7. And then we end by 11, 12. So it's enough compulsory.
No.
Use the system. Is it?
Here. I think he has saved it on this thing. Let me send it to my USB, some of the presentations. But it came very nicely, right?
Yeah, yeah, very nicely, and even these people.
Hmm.
Sir, there are rumors that conference will be cancelled, is it?
No. They're sorting it out. Don't worry. Somebody, a silly fella, has come to him.
Presidential dinner is a conference.